Excellent. Well, I want to welcome everyone to our celebration of Global Health Day. I am Tom Quinn, Director of the Johns Hopkins Center for Global Health and Professor of Medicine in the School of Medicine and Adjunct Professor in both Public Health and the School of Nursing. It's my honor to welcome you all to today's activities with the theme of rethinking global health through synergistic co-creation. The day has been designed to highlight the topics of equity and health, the cooperative spirit in setting mutual agendas between partners, and promoting unique and imaginative innovations in global health. This day's activities have been carefully planned and are jointly sponsored by the Center for Global Health and the Department of International Health. It was designed to integrate panel discussions, a unique, innovative pitch contest, a keynote lecture, and virtual student poster session where you can meet each presenter and have in-depth discussions on their project. But first, I want to make a few comments to start the day. As all of you know, the world has suffered tragically over the past 2.5 years from a viral pandemic that continues relentlessly today. The numbers are truly numbing. 500 million people have been infected, killing 6.25 million people globally. Even in the United States, 82 million people have been infected and 1 million have died. And these are probably all underestimates. Equally, the response to this pandemic has been truly remarkable. Rapid developments of a vaccine and medicines that are effective in decreasing hospitalizations and deaths. Over 60% of the world's population has been vaccinated. And yet the distribution of vaccines and medicines has been unequal, creating this inequity that remains pervasive in this global society we live in today. We must address this inequity, or we will continue to see new variants emerging and persistence of infections and fatalities in many countries of the world. It is that inequity that's going to be a big focus of today's activities. Now, I'm an optimist, so I'm going to focus on the bright side. And the bright side are our students and the faculty of Johns Hopkins, along with their international partners who we're going to hear from in the next panel, that continually strive to push the boundaries of global health and equity for all. That's what we are celebrating today. Even though travel has been limited due to the pandemic, it has not dampened the enthusiasm of our students and our faculty to work together on their global health projects. We will hear from them this morning, but this year alone, the Center for Global Health received over 105 applications from our students and 24 from residents and fellows for awards to work with our dedicated faculty and their partners overseas and internationally. This is a record for sure, particularly with a pandemic raging away. Even across our virtual events like this, hundreds of people from over 100 countries have logged into our virtual global health seminars over the past 2 years, including the very popular monthly series run by Dr. Anna Kabarzik on women in global health. The enthusiasm to improve global health has truly been phenomenal and only grows daily. So what is the agenda for today? It's located both on our website at hopkinsglobalhealth.org. It's also on the info link on the Gather platform, and you can easily access it there. We're first going to host a panel discussion on setting a shared agenda with outstanding experts from overseas. And after a tea break at 9:30 to 9:45, we'll take a little break. We will then host the Global Health Innovation Pitch Contest. with a $50,000 seed grant from the Hopkins Alliance for a Healthier World being given to the winning team. Multiple teams will present their innovative ideas and be graded by a panel of judges. That'll then be followed by a student poster session, which is highly interactive and you will all enjoy. And at noon, we will host the closing keynote presentation by the Dean of the James P. Grant School of Public Health from Dhaka, Bangladesh. Before I hand this over, a few house rules. And I have about a minute on the house rules. The most important person who's put this all together is Megan Harrison. If you have any questions during the day, reach out to Megan. It's megan@jhu.edu for support. Feel free to introduce yourselves in the chat box. We'd love to hear who you are and where you're presently active. Please ask all questions in the Q&A box, and we'll monitor that constantly. You joined the webinar from the Gather platform by entering the seating area and pressing your X key, and then clicking on the Zoom link. When we end the session, you'll be returned to the Gather screen. Feel free to mingle, network between sessions in Gather. When it's time for the next session, please return to the seating area, type the X key again, clicking on the Zoom link. When using Gather, please join with a computer, preferably using either the Chrome or Firefox browsers. This is really Megan's expertise, so feel free to reach out to her at any time. But I'd like to really hand over the session now to Professor Alain Labrique, who's the Associate Chair for Research in the Department of International Health in the Johns Hopkins Bloomberg School of Public Health, who will introduce our esteemed panel, and we'll move into that session right now. Alain, it's all yours.
Wonderful. Thank you so much, Tom, and a good day to all of you. A warm welcome to the virtual Bloomberg School of Public Health on Gather. And on behalf of the Center for Global Health and the Department of International Health, we could not be more honored than we are today by our distinguished panelists' presence. And we thank you in the audience for your time and engagement over these very important conversations. So I'm Alain Labrique, a professor and associate chair for research at the Bloomberg School, Department of International Health. And I have the honor of serving as the facilitator for this panel on setting a shared agenda, looking at the issue of improving equity in global academic partnerships in responding to the needs of hopefully what we can soon call a post-pandemic world. Let me start by introducing our distinguished speakers for today. We have with us all the way from Uganda, Dr. Professor Rhoda Wanyenze. She's the professor and dean of the School of Public Health at Makerere University and has vast experience in infectious diseases research, capacity building, and program management. She has served on various technical committees of the Ministry of Health and other agencies and boards of several international organizations. Dr. Wanyenze is a physician currently serving as the dean of the Makerere University School of Public Health, which is part of Makerere University, Uganda's oldest and largest public university. We also have with us Magnus Conteh, who is the founder and CEO of Exuberance Global Solutions Africa Limited. He's a visiting scholar in global health and social medicine at the Harvard Medical School and a verified mentor and advisor and the executive director of the John Maxwell team. He's a public health expert and leader. Mr. Conteh has led global community health programs and served for over 25 years at the senior leadership level of numerous international development agencies, from Last Mile Health to World Vision, forging global strategic partnerships in health innovation. Last but not least, we are very, very excited to have Dr. Francis Omaswa. who is Executive Director of the African Center for Global Health and Social Transformation. He's a fellow of the Royal College of Surgeons of Edinburgh and a founding president of the College of Surgeons of East, Central, and Southern Africa. He also is a senior associate at the Johns Hopkins Bloomberg School of Public Health. And until May 2008, he was special advisor to the WHO Director General and founding executive director of the Global Health Workforce Alliance, one of the chief architects of the Global Fund and the founding chair of the Stop TB Partnership. Dr. Omaswa has been a key leader on the global health landscape for decades. So today's Global Health Day theme is Rethinking Global Health through Synergistic Co-Creation. And I know it's a bit of a mouthful, but let's unpack that for a second. Our panel discussion really plans to focus in on the question, as Tom put it a moment ago, of setting a shared agenda. After the sobering experience of these last 2 years, we've learned a lot about what works well and what seems to be broken with regards to our global health community. So to begin, I'd like to first quote Dr. Isaac Olufodewa, who is the executive director of the Slum and Rural Health Initiative in Nigeria, who in a recent Lancet commentary says to robustly answer the question of what is wrong with global health, we need to also ask what is right with global health. He cites the 38 million lives that were saved over these past years by Global Fund interventions, the $10 to $41 billion increase in global health funding, and the general improvement to healthcare access that accompanied these improvements. He continues that dismantling inequities in global health must involve bridging the huge capacity divide between professionals in high-income countries and low and middle-income countries. So my first question to our panelists is, each of you has led major initiatives to increase opportunities for young researchers based in LMIC institutions, that you have worked to build competitive competence in the knowledge economy by strengthening world-class infrastructure and training opportunities. Could you each perhaps speak to two priorities which might accelerate progress in developing training and infrastructure in a post-pandemic era? And I can open the floor up and ask perhaps Dr. Wanyenze to answer first.
Thank you, Alain, and a good morning and good afternoon, everyone, wherever you are. So two issues I'll start with is rethinking the competencies and rethinking the infrastructure and systems as well as models of teaching in summary. Now, getting back to the competencies, based on the experience we've just gone through with COVID, but also with the many other impending complex global challenges. We now have climate change and health. We have issues of antimicrobial resistance and so many other complex challenges. One of the issues that stands out and a question that we must all ask ourselves is, do we actually have the right competencies to solve complex global challenges that transcend borders? Yes and no, but there are certain things that really stick out that we are all talking about a lot right now. Issues around critical thinking, innovation, and creativity. How can we actually develop a workforce out there that can deliver within complex challenges, real life challenges, and working in environments across borders, working across disciplines, working in complex political environments, and sometimes in conflicts, such as what we have today with a war that's currently ongoing. How can we actually work within those kinds of environments and also be able to deliver? I think we need to actually rethink the competencies. And as we think about that, we also need to rethink how we train. The systems, the available infrastructure, the opportunities for exposure to the real world and problem solving, so that we go beyond knowledge and basic skills to actually thinking and working on context-specific solutions. So we need to be thinking about systems and opportunities to expose our trainees to, including community laboratories where we can have access to real challenges that our trainees can work on and work across disciplines, work across borders and geographies, and also work with communities, with politicians, because this is the real world that they will work in when they're eventually released to solve problems. So we need to be thinking about that. It needs forging partnerships and working across boundaries. For example, we've been having a program with you at Johns Hopkins where we've had students come down here, but perhaps we need to rethink those programs and how well they've worked and how we can improve them so that we have proper synergistic and equitable partnerships and co-creations with students across different geographies. And we can do this by traveling, but now we know we can also do it in a virtual sense, like we are doing today, including having to build proper ICT infrastructure in an equitable manner that it's accessible to trainers and trainees. And we can actually have virtual labs where we can have our trainees solving problems across borders. So we need to be thinking about the competencies, but we need to think about the platforms, the systems, and infrastructure that can make this happen in an equitable manner. And I would like to say that the overriding aim should be equitable spread of competencies across the world in global health. We can no longer rely on one part of the world to supply skills and competencies to solve global problems. That is not workable, as we have seen in COVID, and that is not going to work when we think about climate change and so many other challenges that we face now and in the future. That equitable spread in competencies will require equitable spread of opportunities, tools for training, and many other opportunities, including working out how we can be able to collaborate in an equitable manner to make that happen. Thank you.
Yes, very, very thoughtful response, Dr. Wanyenze. This idea of competencies that transcend borders, but also strengthening local capacity to problem solve, but also taking advantage of what we've learned of transnational collaborations for training and knowledge exchange, and the fact that we could have virtual labs to assist cross-border problem solving. Let me go to Magnus next, if you would like to take a stab at the question.
Thank you, Alain, and thank you, Professor Rhoda. I just would like to build on a couple of points that you referenced around the use of digital and virtual training opportunities. My previous role with Last Mile Health was as the founding executive director for the Community Health Academy, a global initiative that was set up to leverage the power of digital technology and digital solutions and platforms to provide at the last mile up-to-date training materials and information necessary to build the capacity of frontline health workers to deliver primary health care at the last mile. And I think that initiative really speaks to the issue of access to high quality education. Distance, location should not be a barrier to providing the level of knowledge and competencies and skills required to deliver healthcare wherever the individual is, wherever our patients are, wherever our beneficiaries are. We are talking about equity here. We need to talk about access to that healthcare that is a basic human right for everyone. However, because of location, we are not able to build the competencies of our community health workers and other frontline health workers to deliver that high quality care that is required. That notwithstanding, I mean, when we established that initiative and created the necessary partnerships globally, with Makerere University being one of those partners, with the Ministry of Health in Ethiopia, in Uganda, in Sierra Leone, in Liberia, and in Malawi, we partnered with academic institutions as well as Ministry of Health and Ministry of Education partners to facilitate the delivery of those training programs. And we ran into difficulties in some of the countries because of poor infrastructure. So even though the training materials were available online, free to access, the availability of electricity when computers were available became a challenge because there wasn't enough power to power the laptops to access the training materials. When power was available, there was the issue of access to the internet, the networks, the online networks, to allow our frontline health workers to access training. So building that infrastructure for connectivity and power alongside with making online training materials available globally, free to access, are two areas where I think a lot of work, a lot of investment is still required if we are to change the power dynamics, if we are to change the skills gap, we are to improve that skills gap that we experience in low and medium income countries. I think there is a lot that can be done by our global partners, our donors, as well as those research institutions that come up with new training materials, new training skills that are required. But of course, online training needs to be matched in a kind of blended learning approach, wherein a face-to-face training, skills lab at the front line, still to augment the online training that is required. And I think these are areas where there are still some gaps, and we have a lot of opportunity here to make a difference. And I think the COVID outbreak really has drawn more attention to the power of online education and online training. I mean, when we started the Community Health Academy, we were struggling to convince some countries, some ministries, some governments to take on online training and virtual education. But once COVID became a global issue, very quickly, we started to build those partnerships and collaborations, and a lot of interest was drawn towards the power of online education. But I want to underscore the importance of blended learning, because for clinical training, it is not just enough to deliver online education, but also having skills labs, face-to-face training, and supervision at the front line to improve those skills. Those are my contributions at this stage. Thank you, Alain.
Yeah, thank you for that, Magnus. Yeah, so clearly, I think we do have a digital opportunity to provide high quality training, no matter where one is physically located. But I think these partnerships between training programs and academic institutions have to be strengthened, but there's an underlying need to strengthen basic enabling infrastructure. And I think the investments that have to be made remain in this foundational infrastructure to enable these breakthroughs. Certainly, as you point out, COVID has prompted a lot of innovation, but hopefully we don't lose steam as people start to lose interest in COVID problem solving. Professor Omaswa, can I invite you to weigh in on the issue?
Yes, good afternoon, good morning. We are in different parts of the world. A very exciting conversation that we are having here. And you asked us 2 points regarding infrastructure and training competencies. My observation for the purpose of this discussion is that, one, global health to me has been very, very successful. There are downsides, but if you look at the net, global health has been very successful. However, for us to go to where we really want to go, have competent health professionals whom we can share around the world, we need stronger health systems in countries. We need stronger leadership in countries. There are global tools which are available. but we are not able to make full use of them. And why? In my view, right now in Africa, there are two issues. The issue of regulation of training institutions, assuring quality of graduates. Regulatory institutions exist, established by law, but most of them are underfunded and are not able to perform their job to the required standards. They have issues with political interference in their work. There has been a massive proliferation of private training institutions when we talk about infrastructure. Some years ago, I was a principal investigator for the Medical Education Partnership Initiative, MEPI. And over 5 years, we worked with 13 medical schools, more than that, in 12 countries. And we observed that private training institutions have mushroomed in Africa. And it is an issue to regulate them because some of them have political connections. The quality of their graduates, you sometimes know are not right, but you just watch it, you can't do much because the regulatory institutions have got the same capacities. So I would like us to call for a movement which will enable us to have a global accreditation mechanism to be able to award portable qualifications and to enable a global mechanism to exist which accredits and assures quality of trainees. So am I just talking? No, I don't think I'm just talking. I think this is possible. There are people working on this already globally, and I would like to see how we can support them. So to me, I would like us to use the existing tools which are there. They are there. Competency standards have been set globally. Even mechanisms to share graduates through the WHO code on the international recruitment of health personnel, the very beautiful document which can be used to have this global pool of portable graduates who can be shared in a common pool for all. So that is what I would like to contribute at this stage, mainly to call for stronger regulation and for the global community to get together to make sure that in all countries, particularly here in Africa, we have mechanisms for assuring quality of graduates. Thank you.
Yeah, thank you, Professor Omaswa, for giving us that I think positive take on the issue. That global health, despite all of the criticism that it has received over these recent years, has been overall successful from a macro perspective. But your point that we do need stronger health systems and regulatory oversight of country level capacity is also very well taken. Strengthening regulatory institutions, both from funding and protection from political interests and assurance of quality are key to strengthening institutions. Your call for innovative mechanisms is I think also well received by all of us, and your exhortation to use existing tools such as the WHO pool of sharing capacity is also one that we should take seriously. Let me then move into our next question, which builds on this, and that is really about the ingredients that we need to break through problem solving and achieve scientific achievement. This is collaboration, right? Are there, as we've seen based on our experience over the last few years, sufficient mechanisms for South-South and for North-South collaboration in academia and in scientific discovery. Each of you in your remarks over the last few minutes has noted that there are mechanisms, but those aren't robust enough or strong enough to move us forward. And so given what we've seen in these last 2 years, what do you think has worked well to foster scientific discovery and academic collaborations, but what do we need to do better? Let me maybe move to Magnus first, and then we'll go to Rhoda and Francis.
I mean, this is a very important topic to be discussed in this type of convenience, because as you can see with COVID outbreak, the scientific knowledge for vaccine discovery and production and distribution sits in the global north. And what we find is access to these drugs is also problematic because the global north prioritizing their populations. Now, why can we not produce this in Africa or in other low and medium income countries to serve our populations? Is it because of funding? Is it because of scientific knowledge? Is it because we do not have robust enough collaborations to make this happen? Now, I'm excited to hear the initiative that has been led by Africa CDC to start to manufacture vaccines in Africa, on the continent, so that when we have this type of outbreaks, we have easy access, because the scientific knowledge is there, the infrastructure can be built. It's the same with academic pursuits for research and innovation. The brain power exists in Africa to be able to lead some of this scientific research and innovation. Well, how much funding is available or how much collaboration exists is what we need to be looking at, that prioritizes the local knowledge and local expertise. Now, there are a number of collaborations already that exist with across north-south sort of collaborations that allow for huge grants to be acquired and for innovation and research to be undertaken. But the hierarchical nature of those partnerships itself, it needs to be further examined to improve the access to the high-level research instruments or research infrastructure for the African partnerships or the Global South partnerships or partners to lead on some of those innovations and research interventions. In terms of South-South collaboration also, there are academic institutions in South Africa, in Uganda, like Makerere University in Ethiopia, that are leading in academic pursuits around research and innovation. But there are other countries, including my country, Sierra Leone, where I am currently, and I'm based here now full time. Our academic institutions do not have enough capacity to be able to participate in the type of research and innovation that will address our own local issues here in Sierra Leone, let alone help or contribute to addressing issues across the continent. I think more deliberate interventions need to be made in terms of building those partnerships and collaborations to share knowledge and expertise across the continent, to strengthen the capacity of countries which are still lagging behind in terms of research and innovation and competencies and capacities to publish and become recognized, but also to come up with the innovations that are specific, are context specific to these countries. So I think in terms of funding also, our donor partners, I think, have a lot to do to improve in terms of the collaboration that is available, by encouraging the building of consortiums with the Global South, or even South-South collaboration in a consortium that would allow for more capacity to be built, more innovation to be context-specific for those people, those researchers who are in those countries that know the context, the sociocultural dynamics that impacts on some of the challenges that we are facing within the low and medium income countries, so that local innovation, local capacity could be further built to improve in terms of finding global health solutions that affect our various countries.
Thanks for those thoughts, Magnus. I mean, really, you cover a wide range of opportunities and challenges. But let me ask Professor Wanyenze, who really has been leading one of the largest institutions in East Africa, building capacity and generating that in-country competence, not just to respond to needs of Uganda, but of the continent and the world. And you know, how do you respond to some of those calls for action that Mr. Conteh has just raised?
So thank you, Alain. So I see a number of opportunities in terms of partnerships, but perhaps just to build on the submission from Conteh, going beyond the academic partnerships between academic institutions to the private sector, as we've seen that this has actually accelerated development of tools, including vaccines for COVID. But we have to look at the entire spectrum from the discovery to doing the clinical trials and moving into production, as well as distribution up to the community level, to the individuals that need it. So this needs a wide spectrum of connections and partnerships. And perhaps we haven't developed the partnerships between academic institutions, industry, policy and implementation, and communities, as well as we have done in terms of partnerships between academic institutions. So that's an area that we need to look at. But also looking at the experience we've just come through, building on the structures that we have. In Africa, for example, we have the Association of Schools of Public Health in Africa. It's a structure that provides an opportunity for us to work across schools in the region, and addressing some of the issues around standards and quality that were raised by Francis. But this structure has not been supported well enough, and it's not as functional as it ought to be in terms of realizing its potential. So hopefully with the emergence of regional structures like the Africa CDC, we might be able to realize this, because we already have discussions going on around issues of standards and quality for workforce training beyond the manufacturing and discovery capabilities that Conteh has measured. So we do have an opportunity there, but we also need to realize that this is a young structure that needs a lot of support and sustained support to the right intensity for us to be able to realize the full potential that it offers. In terms of the connections, north to south, that is also really critical, because where we have technology as well as skills and all the tools in the north, we have the opportunity to transfer this, but then we have a number of challenges that we need to work on, issues around regulations, issues around patents that have been raging for quite some time, also need to be able to, come into the conversation if we are going to make the transfer of skills, technology, and knowledge freely to be able to flow from the north to the south, but also from the south to the north. And I would argue that when we look at the South, it's not just an issue of equity in terms of making sure that the South benefits, but the South also has a lot of capabilities, and that being able to bring that capacity to full potential is a benefit for the whole world, because we also do have an opportunity to contribute to innovations that can support the whole world, not only in just technology, but also looking at local approaches that are context specific in terms of improving global health. as a whole. So we need to look at it as a benefit to the whole world when we have these discussions. In our experience, there's a lot of opportunities in terms of learning across countries, across regions, because my school is fairly highly networked. We are currently working with 18 countries in Africa. We are working on issues of capacity building and research, and we realize a lot of opportunities, common challenges that we have, and solutions that we can co-create as well as also develop and be able to stop the duplication and fragmentations that's sometimes quite inefficient. But we also have a lot of good partnerships with northern universities, including Johns Hopkins. So I hope that we can grow this further and look into what has worked and what we can strengthen to be able to contribute not only tools, but also perhaps pilot some of these models that we are talking about and study them and see what they lead to in terms of improving global health so that we can work together. I think we also do have an opportunity to help break the barriers. We have a lot of challenges around power relations. We have neglected the issues of collaboration, and we assume that it's something that will just happen. We talk about it all the time, but it looks like it's a field of study in itself. How can we actually work together across academic institutions in the south to south, north to south, working with communities, working with policy, working with regulators? How does this actually happen is something that we need to think through. If it were easy, it would already be happening. The fact that we are still talking about it today when it is so crucial shows just how complex it is. And we can't just leave it to evolve on its own. We need to be able to contribute to this so that we can advance collaborations and accelerate the transfer of knowledge, technologies across north-south, south to north, as well as south-south. Thank you.
Thank you for both of you for those really deep remarks. I think this idea of strengthening regional collaborations and investing in nascent structures that facilitate those collaborations is absolutely critical. But I think your point and correction of the importance of transferring skills bidirectionally, that these regulations and patents that act as obstacles or bottlenecks have to be addressed. But thank you for correcting me to speak about South-North collaborations, because those are critical to help solve problems for the world. We mustn't be afraid to identify and confront inequities in power relations, but these have to be studied carefully and understood so we can deconstruct and dismantle these longstanding structures. Professor Omaswa, let me ask you to weigh in on these really critical issues.
Yes, it's very interesting and exciting. I would like to build on what my two colleagues have already referred to, and also to address your question of what has worked well, what has not worked well, and why. Over the last 10 years or just more, there have been major transformations here in Africa in terms of partnerships and structures. Following MEPI and NEPI, I don't know if you know those abbreviations, Medical Partnership Education Initiative, Nursing Partnership Education Initiative, we merged this to create what we now call the African Forum for Research and Education in Health. It is abbreviated as AfriHealth. And this group now are firmly established. Their head office is in Kwame Nkrumah University in Ghana. And we have worked with the CUGH, Consortium of Universities for Global Health, closely. And these structures are there. They are nascent, as we say, but they exist and offer opportunities for partnership, for collaboration, for joint learning. And I would like to see us as a global community supporting this development in Africa. Through the MEPI, we got, again, tools which are available there, and they are written up. Good, successful examples are available in how to produce or create a state-of-the-art health professional training institution, curriculum development, establishment of research support centers, medical education units, and then collaboration, south to south, north to south. And those tools are there. Even north to south, as has been stated by Rhoda, it is not a one-way direction. A friend of mine from the UK, Lord Nigel Crisp, has just published again a book which the title is Turning the World Upside Again, because he wrote one before which says Turning the World Upside Down, basically saying that it is bi-directional learning. The practitioners, including the teachers from the rich countries, have so much to learn by coming to learn and rather to work with us in the South. So I would like to call for mechanisms where we can create more cohesion, more support to the existing structures. Rhoda mentioned about the African CDC. Very good, the African CDC has come, a new kid on the block. I would like to see them not duplicate or work as if there are no other institutions in Africa. That is an issue. So the WHO is there. They have programs on health workforce. There is the African platform on human resources for health. There are this AfriHealth and so on. Can we get cohesive on this so that we mobilize resources from our partners and from ourselves to ensure that each and every institution has access to support with the existing knowledge already? And we have ICT. It can enable us to do very many things with the North, between ourselves in the South, and the leadership of these institutions should be supported and encouraged. They have programs, they meet. I think AfriHealth is meeting in August in their annual symposium. What are we going to talk about? These are the things which we should be going to talk about. These are opportunities which, as Alain, you asked what has worked well and what has not worked well. I think we have things which have worked well. We have things which have an opportunity to work well, but may be an issue which we need to talk frankly about. So let me stop there. I think it is possible to work together, south to south, north, south, and even a mixture of both. And the tools, rather the institutions are there, the tools are there. Let's do it. Thank you.
So thank you so much for being our resident optimist for today's panel. I think it's just fantastic to have, these three complementary perspectives, and each of you has raised, key areas of success in global collaboration, but there are clearly substantial progress that has to be made if we are to move forward. But you raised this important issue of funding. And I think each of you has been phenomenally successful in mobilizing resources to support large-scale global health investments. So despite that, data seems to suggest that much of the investment in global health research still continues to go to what are called the prominent research institutions and enterprises in the global north, usually led by well-established researchers. So how can we as a global health community advocate for and achieve meaningful change in this status quo? Magnus, maybe you'd like to take that first.
Yeah, thank you, Alain. As I mentioned in my last contribution, the issue of allocating resources for research in global health has to be addressed. It really needs to be addressed if we are to address the issue of equity in access to resources, access to skills and knowledge and competencies. The barrier that is set for applying for some of these grants, some of this funding that is available is so high that only those well-established research institutions and researchers meet the requirements. And they then partner with institutions or individuals or research institutions in the Global South. And then, of course, we all know the power dynamics there, the access to the funding itself, how the funding is allocated, and even in terms of the allocation of PhD students that are embedded within these research grants. The percentage of Global South PhD students or candidates compared to the Global North is not equal. And you can see by the end of the research grant, you would probably have 10, 15 or more masters and PhD students graduating and publishing from these research endeavors, when in fact most of the data collection itself, it's been done by Global South students or nationals. And that in itself is, it points to the issue of equity. And if we say, because research capacity is not there, or historically or track record, people do not meet the bar in Global South countries to apply for these research grants, and that's why the research grants, it's a catch-22 situation. We need to build the capacity of Global South institutions and researchers to be able to meet that bar. Or on the other hand, how about lowering the bar for applying for those grants, successfully acquiring those grants, so that they could be led by Global South institutions to continue to build the capacity to be able to access and acquire those grants going forward. So we do have a duty and a responsibility within the global health community to continue to advocate with funding institutions to ensure that we level the playing field and allow for more acquisition of grants by institutions in the Global South, and that our students, our PhD and master's candidates in Global South institutions are given more access to this data which they collect to be able to publish and get the requisite experience and qualification and publications behind them to be able to continue then to apply for more research grants. So there is a strong need for advocacy here, which we should not just leave on a goodwill nature, but that those of us who have had the opportunity to work internationally, to be vocal and have a voice in international development, to continue to put these issues on the table. So I really thank you, Alain, for asking this question and making it a point of discussion in a sort of webinar of this nature, celebrating the Global Health Day. So thank you.
Yeah, thank you, Magnus. I think you are absolutely correct. We must use our voice and our privilege of the global ear to advocate for the equitable distribution of these resources. The bar of entry is something that really needs to be revisited to see whether it needs to be modified so that folks can access these opportunities. And also the allocation of these resources has to be revisited to ensure that there's equity in how we invest in students and scholars from the Global South. It's a catch-22, as you say. So we have to be able to break that cycle. And importantly, access to data to advance publications from the Global South. Dr. Omaswa, what do you think about the current bar of entry and allocation of resources?
Yeah, this is something we have grappled with for such a long time. And I'm an optimist, as you can see. I can see light at the end of the tunnel. For example, here in Uganda. USAID for a long time has been saying we are going to move so much % of our grants to local institutions. And there is a call out right now. It's small, $3 million over 3 years. Only indigenous organizations can apply. Can you imagine? That's a big progress. Then they also have a big call, $170 million. So that one, here again in Uganda, the US agencies are here persuading us to go with them as leaders, but we have an option to be leaders ourselves in this call. Do we have the courage to do so? So part of the problem is with us, having faith in ourselves and challenging, or shall we? I want to be unfair to call it calling their bluff. It's not exactly like that. I believe that they are serious about this, but we need to step up ourselves to claim our place and present credible proposals. In any case, a lot of the times research and what we are the ones who do the work. The other people take the money and pay us what they can. So I would like to conclude this bit of this discussion by calling upon ourselves to step up and claim our ground and see what happens, because it will not happen if we just there waiting for the other people to give it to us. How is that?
So that's a perfect setup then for Professor Wanyenze. I think the challenge has been set, step up and claim our ground. Is Makerere stepping up to the challenge, and what do you see as being priorities there?
Yes, we need to step up and claim that space, and we are trying to do that in terms of coordinating with other institutions in Africa so that we can work together. And then we are working with very many of such institutions. And I also do appreciate that the terrain is changing with the localization agenda, but it's perhaps not changing fast enough. And we need to work at certain bottlenecks. If we think that this is critical enough, we need tools, we need timelines. I know we do have some tools, but we need really timelines for action. We have timelines for eliminating HIV, malaria, and TB, and many other things that we think are important. We need timelines for action in terms of shifting the agenda and revisiting the global financing mechanisms to make global health more impactful and to make sure that it's sustainable, but also to avoid locking out critical skills and experience from the South. So we need timelines towards that to drive us to action. And I would like to also perhaps add my voice to this issue of the bar. I don't know if it's a bar that we are lowering. I know Magnus talked about lowering, because that assumes that the criteria for review and selection is fair, and that perhaps some submissions are simply substandard. But I think there is an issue with the entire process of generating priorities, of reviewing and selection that needs to be looked at. That is perhaps more like adjusting the criteria to level the ground rather than lowering the bar, because that comes with a thinking around issues of affirmative action and perhaps funding substandard proposals, which is not necessarily what the case is entirely. The other issue that I think we need to be looking at is other changes in the processes that can support institutional growth. For example, if I could just use the issue of overheads, you can hardly get an overhead cost in a grant. Professor Omaswa with USAID, even when you respond, and if you do, you'll be lucky to get it above 10%. That's not the case with what you get if you were located elsewhere. So how are you expected to have strong enough systems that can respond to the rigors of managing that grant very efficiently and having the high caliber staff that you need to actually run it? We still have certain issues that we need to think through in a broad sense to make this a reality But certainly the terrain is changing. We do appreciate the efforts for localization, and we do have the challenge as local institutions in Africa to step up and be able to support one another and work within networks, exchange learnings, and make this a reality. Thank you.
If there was anyone who joined this morning thinking that they were in for a sleepy panel, I think they're sorely disappointed. And this, by the excitement into this conversation has woken everyone up on this side of the ocean. So I think all of your interventions have been really thoughtful and provocative, really to all of us. Thinking about the intrinsic fairness in the system and the priorities that are being set, not necessarily by the countries, but by the institutions from which funding is being made available. And I think not so much lowering the bar, but redefining the goalposts themselves is where we need to be heading. So I think there's some foundational questions that you've all raised, and one that I think we shouldn't just leave out there as academic conversation, but as you say, Dr. Wanyenze, that we do need a time frame for action and a clear agenda for things that need to be changed. So perhaps that's something that comes out of this early morning discussion here on the East Coast. So let me now move, as we're coming to our last minutes in this panel, in this really exciting discussion, to talk about the trauma that we've lived through globally as a community in this pandemic. And right now, as we speak, many are rallying to formulate the research agenda for future resilience. So in light of your last comment, Dr. Wanyenze, of setting the agenda, can you describe a research priority that you believe is critically important to bridge inequities and dysfunction that we've seen across so many layers of global health systems, whether these are research priorities in allocating resources or even in mitigating the impact of future pandemics? What is your priority?
So in terms of the focus in global health, I think our priority right now, we are driven to health security because of the challenges that we are in. But underlying that is the bigger issue of the climate change and what it's doing to us in terms of the ecosystem for breeding the bugs that we are struggling with, but also food security and many issues. There is something around there that perhaps hasn't received sufficient priorities. And in terms of funding, in terms of actions and timelines as well. And I think we need to be thinking about this really urgently. I know that perhaps it might begin to change because of the war and because of rethinking of energy and what sources of energy and from where. But I think we need to have this issue on the agenda in a more comprehensive way. And there are many others in global health, so I will not list each and every one of them. But I think the real urgent priority is rethinking the global health financing architecture, because it's hurting us big time in terms of identifying the priorities, such as the example I've just given, in terms of who gets funded, what interventions, and fragmenting and duplication. And Francis has just talked about a number of systems, for example, and structures for just workforce alone in Africa. Why do we have so many in the first place, and why aren't they coordinated? Because we are funding them separately, and each funding mechanism is creating its own structure, and then we are now struggling then with thinking, how do we coordinate them? So there are a lot of issues we are struggling with in terms of inequities, in terms of fragmentation, whether it's workforce, whether it's other global health issues that are all rooted within the global financing architecture that is disrupting the cohesion at the lowest level. And this should be something that's really important. I know it's political, it's many other issues, but we just cannot get it right if we don't deal with that. So I think it's a priority for study in itself in terms of moving us forward. And perhaps we can also invest in thinking beyond just health and health outcomes and inequity to inequities within the determinants of health, whether it's commercial, whether it's political, and several others that we need to look at, because we are not going to realize equity in health and health outcomes if we don't deal with inequities in determinants of health. Briefly, those are my thoughts around some of the priorities.
That's a fantastic articulation to take a broad view of these complex problems, but also address the growing fragmentation that has somewhat been exacerbated by the pandemic, but I think that existed prior to 2019. Magnus, your last thoughts on setting priorities?
Yeah, as a global health specialist and if you like, I'm also an executive and leadership coach. I'd like to sort of draw attention to the challenges we have in global health leadership, which manifests itself very clearly in the way this pandemic has been managed, or probably not managed properly or adequately. And to draw attention to the need for building the capacity of global health leadership, and not only at the global level, but also at the primary healthcare level in country. A lot of clinicians are trained, they're well experienced, they're well equipped to deliver clinical care. And more often than not, they find themselves in leadership positions that they are not trained for. Most of our African countries, or even other low and medium income countries, if you go into the ministries of health, most of the directorates are headed by clinicians. And yet we complain about not having enough clinicians in our hospitals, in our health facilities. And whilst that is the case, and for whatever reason that is, they are not adequately trained or supported to perform the roles that they find themselves in. And then when you go to the front lines, you also have clinicians who are practicing clinicians, but yet still they carry administrative responsibilities and roles, either as district medical officers or other leadership positions. How much time and effort are we putting into examining the challenges that these people face and how we could build a capacity to deliver the kind of leadership that we expect them to deliver in their positions? And how much coaching and mentoring can we put in place for them to help them to do their dual roles, clinical and leadership? There's a lot of literature around the use of clinical supervision and mentoring for clinicians in terms of clinical practice, but there isn't enough research that has been done around the use of coaching and mentoring and supervision to support our clinical leaders as they perform their leadership positions. And I suspect that also applies to some of our global health leaders who are responsible or have the duty to provide the type of policies or strategies or implementation planning to respond to this type of global emergencies that we have. I think there is scope there for more research to be done. Part of what I did as a visiting scholar at Harvard University for my research is around the use of coaching and mentoring to support primary healthcare teams in delivering care at the front lines. That is ongoing research. It is not yet ready for publication, but I would like to focus my contribution here to drawing attention to that particular aspect of building the capacity of our global health response to this type of pandemic.
I think that is really a unique perspective, Magnus, to address this dual responsibility that many of us have, not only as researchers and scientists, but as global health leaders and global policy leaders. So I think investing in leadership capacity of the future thinkers and thought leaders in the scientific community across the global south is really critical, and globally to strengthen communication and engagement. Last but not least, Dr. Omaswa, you have been the beacon of positivity in our very heated conversation this morning. Where do you think our focus should be as we move forward?
Oh, okay, right. So during COVID, you talked, Alain, about the catastrophe of COVID. I've spent a lot of time the last 2 years serving as the chair of the National National Community Engagement Strategy for COVID response here in Uganda. And it's been my role to ensure that all the people in Uganda are aware and are doing the right thing in responding to COVID based on village COVID task forces. And with that experience over the last 2 years, it has become even clearer to me than ever before that strengthening community health systems where communities and individuals participate as a duty and a right is the most powerful way of achieving universal health coverage, of addressing and preventing future pandemics. So I would like to see us look more closely into community health systems. They will vary from society to society, from country to country, but by being able to reach households and individuals in households with the right message, the right trusting messages, and addressing their needs. And then above all, getting them to meet regularly for community dialogue, to identify and solve their own problems is a very, very powerful tool for improving foundations of health systems and achieving universal health coverage. I would like us to understand that situation better and maybe to advocate for it and see that this approach is adopted by more and more countries, not just in Africa, but also globally. That is one of my research priorities, and a top one at that. I believe it brings more economic returns than building bridges and dams for electricity and so on. Number 2 is biotechnology. This vaccine nationalism, you saw what happened, became almost an existential threat to us from the South, because those who had the technology to save themselves from COVID were taking care of themselves first. And it took a very long time for them to make these vaccines available to us. So I would like to see us develop biotechnology competencies here in Africa in some organized way. And how do we do that? What resources do we need? What capacities do we need? All these things we talked about just a few minutes ago on North-South collaboration and South-South collaboration. This is the time to do that. I wasn't going to talk about this, but now my friend Magnus has talked about clinicians being managers in health systems. You know, I am a perfect example of that type of thing. I started my career as a surgeon, a cardiothoracic surgeon. I ended up as Director General in the Ministry of Health along the way and so on. And my own interpretation is that growing up all the way from the bottom, it prepares you best for those leadership roles. And of course, you have got to take management training. All of us have to take management training. I'm sure Dean Rhoda has had to do this. And I, for one, I would never be sufficiently grateful to Johns Hopkins. They are the ones who taught me total quality management. And I haven't found something better for making clinicians good leaders, other than to make sure that they understand the principles of performance improvement non-stop all the time. And I learned that from Johns Hopkins. So let me end my contribution there. So community health systems, biotechnology, and let's teach everyone, not just clinicians, but all of us, how to manage. Thank you.
Thank you so much. And with that, I just think of the quote of from Martin Luther King, of all the forms of inequality, injustice in health care is the most shocking and inhumane. And I think the comments that all three of you have made this morning lead us to think deeply about some of the long-lasting challenges that we've been facing as a global health community, the lessons that we should learn from the last few years of surviving through this pandemic. And I think your exhortations to invest in leadership and institutions, in studying the complex systems and determinants of health and of the drivers of health system inequities, but also investing in communities as the foundations to future resilience, are all key to our ability to combat not just vaccine nationalism, but health nationalism. And I think as we move forward as a global health community, reflecting on your insights and your comments, you've really set us up for a thoughtful and thought-provoking day of interaction and engagement across South, North, East, and West as we move forward to building a stronger global health knowledge and action economy. So I want to take a moment to thank all three of you for joining us this morning, and to the exciting group of over 100 people truly from around the world who have taken the time to be here, to join in a conversation in the chat room, and also to listen to your many years of wisdom and experience. So please join me in a virtual round of applause for our panelists, and we look forward to further interactions with each of you. So thank you very much.
Thank you, everyone, for coming back. That was a really riveting discussion, and we're going to shift gears here now and move to the Global Health Innovation Pitch Contest. So for those of you who don't know me, I'm David Peters. I'm Chair of International Health and Faculty Director of the Alliance for a Healthier World. AHW, or the Alliance, it's a cross-university initiative of Johns Hopkins. It brings together faculty, staff, and students from across the university, and as well as our partners from around the world, really to try and unlock groundbreaking knowledge in order to resolve complex global health equity challenges. So we've had funding from the Hopkins president and provost, as well as some other fundings. And a big part of what we do is we provide grantees opportunities to work on global health equity challenges that require multidisciplinary, multi-school approaches. So far, we've given 60 of these grants to date. And then we also help them to obtain additional funding afterwards. So in addition to the grants program, we also have students that are trained in a Global Health Equity Scholars Program. We have events and convenings to help networking and create opportunities for faculty staff around global health equity issues across a range of disciplines. So that's the introductory spiel, and it's really great to be able to collaborate with Center for Global Health and the Department of International Health in Global Health Day. So today we're going to hear from 7 multidisciplinary teams from across the university, and the winning team is going to win a $50,000 grant from the Alliance to really take forward some really innovative ideas. These proposals are addressing, well, I won't go into the details. They're all addressing one of three, or probably more than one of these themes of the health equity at the Alliance, addressing structural determinants of health, common goods for health, and health equity knowledge and translation. To make this happen, we have a series we have 4 judges that are going to, they have the fun of being able to listen, ask questions, and then, sorry, my printer is possessed and making noises in the background. But they'll be reviewing and then coming up with a score, and we hope to announce these by the end of the week. So the judges for today, I'll introduce them to you quickly. Alain Labrique, who you've known from the last session, Professor of Global Health, Global Disease Epidemiology Control. He's our Associate Chair for Research in the Department of International Health, his cross-appointment in School of Medicine and Nursing, and is a founding director of the Global mHealth Initiative at Hopkins. The next one is Julie Messerschmidt, who is the executive director for research at the university and really helps to oversee the development, strategic planning, and implementation of institution-wide research initiatives, really to increase interdivisional, which is interschool collaboration and support excellence of Hopkins faculty. And you'll note that some of these initiatives include the Bloomberg Distinguished Professorships, the Discovery and Catalyst Awards, and the President's Frontier Awards. Tom Quinn, who you also well know, he's Professor of Medicine, Pathology, but also in International Health at School of Public Health and Epidemiology, and molecular microbiology and immunology, and also cross-appointed in School of Nursing, and is the founding director of the Center for Global Health. And then finally, we have Tony Ungaretti, who's professor at the School of Education, founding director and of the Master of Education and Health Professions, which is really another cross-school partnership with medicine, nursing, education, School of Public Health, and the Carey Business School to help with physicians and health professionals with doctorates around the world to become change agents in education, teaching, research, leadership. And we just heard in the last talk of the importance of leadership training for the health professions. So with that, I am going to now turn to our pitches. The order has been determined. I'm not sure how, but I think it was probably random. And we'll give 7 minutes to each team to present. Chris Henry is the timekeeper who will be keeping to that, keeping us on time. And then we have 3 minutes for each for question and answers. Hopefully we can get 1 or 2, 3 questions for each team. So the first team that we're going to hear from is a team of Rama Chalapa and Nakul Shekhawat. And please tell me if I've mispronounced your names and correct them. They're from the Whiting School and the School of Medicine, and they're going to present about a telemedicine intervention to expand access to eye care, and the field work is with partners in India. So with that, I'll turn it over to you, Rama. You're on the center, so I'm assuming you'll go forward with that. Please go ahead. But you're muted, so you have to.
I think Nakul is going to start the presentation.
Yes. And our biomedical engineer extraordinaire, Jordan Schuff, is going to take it away with our slides.
Yeah, can you guys see my screen okay?
Great, looks great, yes.
Okay, yeah, myself, I'm a biomedical engineering student, and then we have Dr. Venkatesh here, who's the Chief Medical Officer at Aravind Eye Hospital. We're going to be telling you about Vigilant today.
Thank you, Jordan. Yeah, this is our first pitch on the Vigilant. So you all know the global visual impairment, the burden of the visual impairment across the globe. We have 1.2 billion, and almost 1/3 live in a country like India, 340 million. And most of it is kind of preventable, almost 80%. If you see this, the map, a distorted map of blindness, the prevalence of visual impairment is so huge in the low middle income countries, as we discussed earlier, whereas the number of practicing ophthalmologists is kind of inverse. You don't have that much of human resources. So to reach the unreached, Next slide, Jordan. So we do a lot of outreach activities. So to reach this kind of problem. So cataract, as you all know, is the largest cause of global blindness, and a simple surgery like a cataract surgery, which takes less than 10-15 minutes, can restore the vision. Annually at Aravind Eye Care System, we screen roughly 500,000 patients to do 100,000 cataract surgeries. In spite of doing this, we have seen a lot of limitations. We have seen that only 20% of patients who need eye care in the zone where the outreach happens really take the care, because it takes place at specific dates, specific times, and in specific locations, still finding it difficult for access to certain people because of the distance, because of the cost, and also the time related. So, and also some of these outreach have high reliance on highly trained eye care professionals, a team of doctors, paramedical, they all have to go there. And some camps are very successful and some camps really become a big flop because of various reasons, and resulting in a kind of expense due to staffing, logistics, and also the marketing towards getting these patients to the campsite. Next slide, Jordan. And more so in the last 2 years, when the pandemic was happening, all the outreach activities were kind of stalled. No, we didn't have permission to do outreach activities. So almost like 500,000 Aravind patients could not access eye care. So almost you have to double this number in the last 2 years, but in between we were able to do a few camps. And this delay kind of led to a late stage, like advanced stages of cataract, even resulting in secondary glaucomas and blindness related to that, which complicated the process. And recently, the government of India released that there is an estimated backlog of 10 million cataracts in the last 2 years, which has to be cleared this year, in addition to the new cases we have to do in 22 and the years to come. So that is where we came up with this kind of a solution called Aroma, Aravind Rural Outreach by Mobile Application by the Vigilant Group. And now I hand over the stage to Jordan to continue the presentation.
Sure. So just to summarize the barriers that Dr. Venkatesh listed, there's access to specialists, distance to facilities, high cost of screening, and general lack of awareness. So we looked at what a solution might need. We interviewed a lot of stakeholders and patients, and we understood that a solution needs to be de-skilled and decentralized in order to make sure that it's reaching the people in the remote areas. It also needs to be low cost, and ideally a solution will be community driven so that we can increase awareness about access to eye care. And so that's where we came up with this Vigilant with this Aroma project, which is an integrated end-to-end patient outreach and diagnosis system, which is optimized to serve eye care systems in low and middle income countries in order to reduce the incidence of preventable blindness and integrate underserved patients into the eye care system. So this solution consists of several components. First is a low bandwidth field application that enables minimally trained users, such as community health workers or volunteers, to screen patients in the field, either door to door or at high traffic areas in their community. And with the mobile app, community health workers can collect and upload ocular history, complaints, visual acuity, and capture anterior segment images. So these images are standardized using a smartphone attachment that can capture diagnostic level images of the eye. And here you can see some examples captured by community workers with less than 30 minutes of practice. And when we had 2 ophthalmologists review these, they found that 95% were of sufficient quality to make an accurate referral. And then using these images and other information collected from the patient, we're developing artificial intelligence algorithms for real-time referral decisions in the field. In a proof of concept trial where we used low quality images captured before we optimized our imaging hardware, we were able to achieve a precision of 92%. However, we've now built a database of 2,000 high quality images. So we're working to develop a more robust algorithm for real-time diagnosis in the field. And then this app seamlessly connects to a backend electronic medical record, which enables ophthalmologists at the base hospital to review information and, if needed, make a final diagnosis and referral decision. And then finally, and probably most importantly, in order to close the loop, Vigilant allows for automated communication, both through messaging and through phone call. So the patients can be easily contacted, referred, and given the proper treatment. And over the course of developing the system, we've screened over 2,000 patients. We also conducted a paired validation study at Arvind against a gold standard in-person exam compared to our telemedicine exam with Vigilant. And we found that community health workers are able to accurately collect information. They were measuring visual acuity accurately in 95% of cases, and that a remote ophthalmologist reviewing information collected by community health workers can accurately diagnose patients in 93% of cases. So we plan to continue to develop the system alongside our partners in India in order to meet the needs of the eye care systems and the patients there. So first, we're going to build upon our previous work and develop robust algorithms for real-time diagnosis in the field. We will evaluate these algorithms in an 1,000-patient paired validation study against a gold standard in-person exam. Next, we'll develop a pipeline for interoperable integration into hospital medical record systems. Our goal is to make sure that we're fitting into the hospital workflow and that we can ensure patients are following up, complying with their treatment, and receiving the treatment they need. And then to further aid in this goal, we'll also develop data dashboards to track outreach patient outcomes and make sure that we're reducing the burden on already limited staff at eye care systems. So our goal is to make the system available and sustainable for hospitals. In order to do this, we're planning to charge a $2 to $3 referral fee for each patient who receives treatment as the result of our screening. And this will ultimately be lower than the $8 hospitals are currently spending to bring in these patients. So really quick to wrap up, I'd like to thank Arvind for this collaboration, thank all of the amazing investigators involved in this project, as well as the team of students and the people on the ground at Arvind making this happen. So thank you, and we'll take any questions at this time.
Thank you, Jordan and team. We'll turn it over to some questions, and I'm going to take them in order, starting with Alain Labrique. Do you have a question for the team?
Yes, thank you for that excellent presentation. My first question is going to be about equity and reach of the solution. Have you looked into the availability and penetration of WhatsApp in the population hardest to reach in this area, and will you be able to reach them with this solution?
Yeah, so we interviewed around 60 patients last time we were in India. And you're right that there wasn't high WhatsApp penetration. So from that, we pivoted. In fact, many of the patients we talked to said that they were illiterate and they would have a hard time if they were getting messages, reminders. But they said that if they received automated phone calls, that would be ideal for them. They also, the majority of patients, over 90%, said that either they or a close family member had a phone so that they could get that follow-up information.
Thank you.
Thanks. Julie, you have the next question. Do you want to go ahead?
Yeah, I was wondering about the potential for scaling. It seems like there might be a bit of a limiting factor with the referring ophthalmologists. So I was wondering how you envision scaling this across hospital systems.
Sure. So that's where the artificial intelligence comes in. Our goal is to ultimately relieve the burden on ophthalmologists in cases that can be handled, that are really standard and can be handled by a computer-based system, to use that, and then to limit the reviewing ophthalmologist to the cases where there's either a low confidence level or it's a more complex case, not like a standard cataract, in order to make sure that this is scalable to hospital systems. Great.
Tom, your question.
Yeah, a great presentation, and you covered a lot of ground. I just wanted to find out of the sort of the specificity of the ocular problems that you might be able to pick up. I mean, your focus has been on cataracts, but what about visual acuity? What about blepharitis? I mean, those ocular exams should be able to detect some of those. How are they going to be incorporated into some of the referrals?
Sure, I can start, and then if any of the ophthalmologists have anything to add, please jump in. So the way that we're designing our algorithms at this point is they don't just use images, but they also use the patient history, they also use the visual acuity, and they use all of that really valuable clinical information we're collecting. So that'll definitely help us to distinguish these different conditions. So at the time, we are currently diagnosing cataract, both immature and mature, as well as refractive error, corneal infections, trauma, and pterygium. So the most common and probably the most impactful cases in these rural and remote communities.
Great. So I think we're now at time for the questions. We'll start the next set of questions. Tony, you'll get the first question next time. That was a great presentation. Let's give a round of applause and thank you for that. And we'll move on then to the next great idea. So here we have a partnership of a team co-led by Vishal Patel from the Whiting School of Engineering and Zabir Hassan from the School of Public Health, and again with partners this time in Mumbai, India, and elsewhere. So let me turn it over to you. You're going to be talking about camera detection on motorcycle helmets used to reduce road traffic incidents or injuries. So let me turn it over to you, and we'll start as soon as you begin the presentation.
Okay, great. Thank you, Dr. Peters. And welcome everyone. I am Zabir Hassan. I'm an assistant scientist in the Department of International Health. And today we are pitching an idea to develop a deep learning based automatic high-speed, high-precision real-time helmet detection system in India. And as our collaborator, we have Dr. Vishal Patel from Whiting School of Engineering and Dr. Vedagiri from Department of Civil Engineering, IIT Mumbai. So, starting with the big picture, WHO estimates 1.3 million deaths every year due to road traffic accident. And the burden of this huge mortality actually leans towards low and middle income country. And if we focus on India, it is estimated that every hour, 4 people die due to road traffic accident when they're not wearing helmets. And if we focus a little bit more, how we are measuring these deaths and how we are measuring helmet use. I am also working within the Department of International Health, which is the Johns Hopkins Injury Research Unit. And within this center, we regularly collect data related to injury risk factor. And in each round, 6 months, when we collect data related to helmet use, at Mumbai, where this research we're proposing, the latest data shows that currently around 75% motorcyclists are using helmets. But when we looked into how they're using helmets properly or not properly, only half of them actually use proper helmet use. So, but when we dive a little bit more into how this data is being collected, we do it by sample survey. So we select 15 locations all across Mumbai from different type of roads, and our data collector sits in the stand in the sun in the intersection when all the vehicles are standing at the stop. We actually count the motorcycle and if someone is wearing helmet or not. So this process is really extensive and robust, and we use a very robust methodology to do it, but still there are chances of human error due to environmental factors, like if there can be rain, there can be a high intense sun, and also you doing it year by year really requires a huge amount of investment and time of data collectors. And the other thing we have to consider that the continuous monitoring of helmet use is not happening while we are collecting the data, because two parts. One, when the motorcycle is stopping at the red light, then we are only counting. And also we are implementing the survey every 6 years. And this is, I think, the only way at this moment, the data is being collected in the low and middle income country, specifically in India. So there is a need of innovation. And what we are proposing, part of this pitch, that we wanted to implement an end-to-end pipeline for image detection through video or still image. So this is an example of how that is being done. So in Mumbai currently, there is a huge resources related to the video storage and the camera system. According to the latest statistics, in each square mile of area in Mumbai city, there are around 154 cameras. And also our local collaborators, IIT Mumbai generally collects the video footage while implementing the survey. So using the deep learning algorithm and image detection system, it is possible to identify specific object from still picture or video system. So what we are proposing here is an end-to-end pipeline where we are using 3 specific components. One is called OpenCV, which is an architecture to build different type of deep learning algorithm, and one of the specific one is YOLO. And YOLO means like you only look once. So this is really funny, but using that, it's possible to identify specific objects. But simultaneously, it's a little bit tricky because we are using video rather than still images. So to reduce duplication, and if we are tracking each person not twice on a single time, we need to have a separate algorithm which called deep sort. So within this architecture, having these 3 components, it is possible to identify a motorcyclist if they are wearing helmet or not, and if they're wearing properly using helmet or not. So on the bigger part, what is our proposed outcomes or intended outcomes? The first thing is we wanted to develop a prototype system which identifies high speed, which will identify helmet using in the motorcyclist with this object tracking and object detection algorithm. Once we do that, the second step is to really doing it in real time from the video footage, not taking the video in your computer and running the algorithm, rather than if it is possible to do it in real time. And the third part is, which is in the future, that if it is it possible to integrate this algorithm within the camera system itself. So there are technologies to do that, like small computers like Raspberry Pi, which can be integrated within the camera system, so that you can we can count the number of motorcyclists wearing helmet in real time and develop a clear data set. But that's our view, right? From a researcher, we want to count and we want to see what's going on. But what is the impact in policy? So India just implemented in 2019 the Motor Vehicle Amendment Act, and it's implementing really harsh penalty for not using helmet or not. But with the sparsity of data, how we can actually ensure the compliance of motorcyclists. So what we want to do, we want to work with our local collaborator in India and our strong presence of the Johns Hopkins Bloomberg International Injury Unit to work with our policymakers to reintegrate this pipeline within the traffic system.
We're at time, thanks.
Okay, so thank you so much. So I really want to thank our collaborator, Dr. Vishal Patel from Vision and Image Understanding Lab, and our collaborator from IIT Mumbai, Dr. Professor Fedegari. Thank you so much. And we will take the question now.
Thank you very much. That was another excellent presentation with some really cool innovations. We're going to start with Dr. Tony Ungaretti. So please go ahead.
Thank you, Peter, and thank you for this presentation. As you were talking, I was wondering, how do you tell the difference in these photographs between capturing a person wearing a helmet and wearing a helmet correctly? And what kind of laws exist in India regarding helmet use?
Yes, thank you so much. So as there's a two-part of question, I will take the later one, and I will request Dr. Patel to discuss about the object identification component. So in India, the latest 2019 Motor Vehicle Amendment Act strictly imposes that helmet needs to be worn. And it's not just a cap helmet; it needs to be a full-fledged helmet with the clasps closed. But of course, what we are looking at during the data, that there's really little compliance, and the compliance is less when it's pillion or who is actually riding the motorcycle, not the driver. So the government of India is trying to implement and working with the federal government and the state government to implement the Motor Vehicle Amendment Act and start implementing the harsher penalties. But of course, progress takes time. But for the detection of a helmet, Dr. Patel, if you want to pitch in here, thank you.
Yeah, sure. So the detection part is something that we work in computer vision. The idea is to first detect the person and then essentially look at the part where the helmet appears, and based on that you can do so-called fine-grained classification where the person is wearing helmet properly or not. So these are some of the things we can do by applying computer vision and machine learning techniques.
Thank you. We have time for another question. So Alain?
Sure. I'd like to ask you about the competitive landscape, because this is a field where there's been quite a few innovations over the last 4 years using AI vision for helmet wearing. How is your innovation different or contributing to what already exists?
So if you look at the existing literature, most of them, they look at very small scale data set, and it's a very so-called unconstrained data set. What we are proposing is to make it real time, as well as look at some environmental factors such as extreme illumination due to sun, or if you have haze or rain, things like that. This has not been looked at in this problem before.
I just wanted to pitch in here. One is the technical part of it, that how we are detecting, but also the another part is implementation. I think with our unique collaboration between the View Lab, the Injury Research Unit, and
We're
our
at time. Thank you.
Yeah, I think we have strong collaboration, and we will be able to do it in the large scale and working with the local and the state government. I think that actually puts us in a frontier of scale up and implementation. Thank you.
Thank you.
Thank you, and appreciate it. Let's have a round of applause for this. Really, again, another very innovative approach, and thanks to the team for presenting. So you will notice that that we have the Q&A section that is open for this. And please feel free to add questions to the presenters, to the teams. There's already been one for the first team, and they've presented and they're answering, and then some while this one was going on as well. So you get some chance for extra question and answer that I think will be helpful for your case as well. So please feel free to use that. So let's move on to the third presentation. This one is going to come to us from the co-PIs are Mario Mesas from the Carey Business School and Ken Stevens from the School of Medicine, and again, the team across Hopkins and others. This is going to be about a technology and approach to looking at blood retransfusion in refugee camps. And I think the base here is in Tanzania. So I will turn it over to the team. In case you don't know, when there's 1 minute left, I put my video back on and I type something in the chat so you know when the time is, because I know we're pretty brutal on time, but thanks for appreciate your patience with that. So over to the team, and we'll start as soon as you begin your presentation.
Thank you. Can everybody see my screen okay? Great.
I can.
Good morning, and thank you all for the opportunity to be here today. My name is Alex Blum, and I am an MD and PhD student here at Hopkins, working with a team of surgeons, an economist, and the Tanzania Red Cross Society. I'd like to start by telling you about Bernadette, a patient I helped care for last month who nearly experienced what the late Paul Farmer would have called a stupid death. That is, a largely preventable death attributable to unjust circumstances and failures of imagination that lead to disparities in access to care. Bernadette is a 39-year-old mother of 9 who came to us bleeding heavily after giving birth in Nyarugusu refugee camp in the western part of Tanzania. Now, this is not an uncommon phenomenon, and yet the rates of maternal mortality across Tanzania are far above international standards and goals. Now, as you might imagine, patients who are bleeding to death need surgical care to control the bleeding, medication to maintain their blood pressure, But most importantly, they need blood. And this is often a really scarce resource in refugee camp settings. We also know that marshaling and coordinating this care is challenging at best and implausible at worst. Exceeding all of our expectations, Bernadette survived and is back with her family now. Just days later, another woman with the exact same condition, postpartum hemorrhage, was not as fortunate. She died. Our proposal focuses on addressing these eminently treatable, stupid deaths, and I'm excited to hand off to Zach to tell us more.
Thanks, Alex. So my name is Zachary Numa. I'm a clinician by training and a surgical resident here at the hospital. I've been working in this refugee camp in Tanzania for a number of years. I'm here also presenting on behalf of Dr. Stevens, who unfortunately could not be here as he had to be in the operating room this morning. And then I apologize to the committee and to the rest of the panelists. Our international collaborator listed here, Dr. Hilary Ngude, unfortunately cannot get the connectivity to join our session. So I will present his part, understanding that this may disqualify us from the competition. Next slide, please. So Alex painted, I think, a very real picture of what a big problem is in the world, but specifically in Tanzania, a place that has one of the highest maternal mortality rates in the world. But there's a device here that can help us, right? So for patients like Bernadette, who are bleeding even after you take them to take out their uterus, there's a device that has been put out by a group called SISU Global Health called Hemofuse. And it's exactly this. You take blood from a patient who's bleeding and you collect it in a large canister, like you can see here labeled on number 1. And it's filtered as it goes in. Then you basically take that same blood, put it to an IV bag or a blood bag, and then transfuse it right back to the same patient who just lost it, right? This is autotransfusion. It's something that we've been using in medicine for a number of years and decades, specifically in something like heart surgery. Next slide. The sort of goal here is that this can be a very low cost solution to a big problem and to really help curb the burden of maternal mortality in Tanzania, among other causes. So Hemofuse, this device, has FDA clearance. It's also recently received full approval from the Tanzania Medicines and Device Association, essentially the FDA of Tanzania. And it can be useful for postpartum hemorrhage, which is what our patient Bernadette had, but for anything else that's causing bleeding into the abdomen, for example, road traffic accidents, a ruptured spleen, other sorts of trauma. Next slide, please. Now, this is helpful on the large scale because I think any of us that read about or are interested and invested in global surgery understand that, you know, over 5 billion people lack access to safe and affordable healthcare, and we need another 140 million operations yearly just to meet the unmet need. Recent work from refugee camp settings suggests that over a quarter, so over 25% of refugees actually have ongoing or untreated surgical problems. And so having a device like this to be able to use in surgery where you often do encounter bleeding can be a huge plus and a huge advantage. Next slide, please. But specifically for us, with regard to maternal mortality, Tanzania still has one of the highest ratios in the world. So you can see here that in Tanzania, the rate is still in the 500s, despite the Sustainable Development Goal target being bringing that number down to 70 per 100,000 live births. And while a lot of progress has been made in recent years in Tanzania, where years ago it was actually in the 800s, it still remains a major problem, both on a clinical level in terms of best ways to treat it, but also on a larger public health level. Next slide. So our project really builds on a partnership that we've had with the Tanzania Red Cross over the last 5+ years. We've, at this point, done a lot of work on trying to quantify and qualify the burden of surgical disease, the burden of C-sections, patterns of surgery. And we've learned a lot of lessons along that way. And now we're interested in how can we implement low-hanging fruit changes, low cost and cost-effective changes to try to meet some of these unmet needs in the camp. And we think, and we strongly believe, that having a device like this Hemofuse device would really help curb the burden of a very common problem like postpartum hemorrhage. So thank you for the opportunity to present. We also have with us Tim Goodwin of SISU Health, who developed Hemofuse, to also answer any questions specific to the device if there are any. Thanks again.
Thank you, and thanks for keeping the time. We get a little more time for question and answer then. And just to also reassure you that nobody will be disqualified because of problems with connectivity. So it's a very nice, impressive proposal. So I'm going to turn it over to our team, and we're going to give you an extra minute to answer more questions. So first up is Julie Messersmith.
Hi, everyone. Thank you so much. This again seems just like an incredible proposal. I'd like to know more about the specific goals of, is this going to be more of a training opportunity for healthcare workers on the ground, or is this more about the ability to purchase many of these instruments? Can you describe a little bit more about what the specific project aims to do?
Yeah, absolutely. So our goal for the project is really to implement it. So that would include purchasing the device and also doing the appropriate training. You know, in the camp itself, this camp has a population of around 130,000 refugees. It's a busy and bustling center. I mean, there's 20,000 outpatient visits a month to the health centers there, and around 600 live births. And each month, the C-sections are probably anywhere between 60 to 100. So part of it will be training, and the group at SISU Global Health has a lot of experience doing this. And then the other part will be, yes, purchasing the device, parts of which are actually reusable, and you can put them in an autoclave to sterilize them.
If I may, can I add? So this is like an incredible, device that could, if scalable, like could save a lot of lives. So understanding, the barriers to adoption, logistical, and so on is incredibly important.
It shows the value of interdisciplinary teams too. Tom, you get the next question.
Yeah, no, thanks very much. Good presentation. I am curious about the device, and there's a bunch of questions as well in the Q&A that you'll see. What's the cost of the hemofuse device? How does it work? What are the conditions it's been actively used in? Thanks. And
Tim.
Where has it been used?
Perfect. I'll pass that to Tim to answer.
Yeah, thanks so much, Dr. Zach, and thanks for inviting me. I want to make sure everybody can hear me. All right. Yeah, my name is Tim Goodwin. One of the senior training coordinator for SISU Global Health, who invented the hemofuse. There we go. It's nice to be able to see myself on there. Do you mind just maybe if I can get that first question again? What was the first question, please?
Yeah, so you could describe this device, but what is the cost? I mean, what is the scalability of using this, and where has it been actively used throughout Africa or in Asia?
Yep. So with the countries in which we have initially launched hemofuse to date and have seen successful uses are Kenya, Tanzania, and Ghana, along with Pakistan as the first 4 countries. We've had hundreds of patients receive autologous whole blood transfusion via hemofuse across large markets in which we launched in Kenya starting in 2018. In terms of the cost, that actually depends on quite a lot of factors. And so what we have seen and what we do for, we typically set as a standard is it costs less than $100 per surgery. The exact cost would depend upon, a couple factors, and some of it with, our company, and, we are very much invested in this project, and we may offer a discount as to what we would sell this commercially at as well. So the cost would be something that works within the scope of the grant and allows the team to treat as many patients as possible.
Great, thank you. You got time for one more question. So Tony, you want to go ahead?
Thank you, Peter. Mario, you mentioned the idea of cultural issues. Could we have a little bit more explanation on what are potential cultural issues or barriers in the adoption of this, and what need is there for education?
Yeah, this is an incredibly important question. Sorry, Mario, if I can just add something first before, if you had any comments. We've as a group done a lot of research in this camp, quantitatively and qualitatively. And actually, one of the things that we have found is that, even some women delay coming to the health center because they fear, well, if I come, I'm just going to get a C-section. Even though the rates in this camp, the rates of C-section is actually around 10%. So it's not as high as some people might think. in that vein, one of the things that we would do is there's a team of community health educators that are employed by the Red Cross, refugees themselves, who work in each of the zones of the camp. And one of their primary jobs is community health education. So an important part of this project would be, for example, utilizing them, many of the ones that we've used for our other studies, in sensitizing the community about this as a technology and as a way that actually may help allay some of those fears. If a woman's fear is, I'm going to get cut, I'm going to die from blood loss, this actually may help us improve relations between the community and the hospital.
We're at time. Thank you.
Thanks, Zachary and team. That was a great presentation. And there's a lot more questions in the Q&A, some in the chat that'll try and move over there as well. So please feel free to answer. Use the Q&A. It's a lot easier to answer there as well. So thanks. We're halfway through. And that's because there are 6, not 7 groups for those of you who are counting. We're now moving on to the next group. This is co-led by Yusuf Yazdi of Biomedical Engineering and Sumya Acharya of the Carey Business School. So I will turn it over to you. Oh, this is about automated microscopy for malaria detection sites in Uganda, but of course here in Baltimore and Dallas. So over to the team.
Thank you very much. If I could request Megan to bring our other collaborators on the video as well. We have colleagues from Makerere University, Jocelyn, and our students on the team, Matthew Ferrio, if they could also speak. So I'll start now. Really excited to talk about this this project with you all. This started with a huge unmet need that was presented to us directly by the leadership of the National Malaria Control Division in Uganda in an unrelated meeting that I was having with them with several of our students, showcasing, demonstrating several of our other recent inventions. And this idea came up from there. And we've been working really closely with the Malaria Control Division in Uganda to take this innovation and really make malaria diagnostics possible at the last mile of the healthcare system. Tier 3 and Tier 2 facilities bring the gold standard of diagnosis, which is microscopy, to places where that skill set does not exist. So with that, I'd like to invite my colleague from Makerere University, formerly of the Ministry of Health in Uganda, Jocelyn Atuerwe, to do the presentation of the need and the background. Jocelyn, over to you.
Thank you. Malaria is a global health challenge causing about 141 million illnesses and 627 deaths annually. Uganda is the 3rd largest contributor to the global malaria burden, accounting for 4% of all the cases and deaths recorded. That's about 20 million people and about 5,000 deaths annually. The disease causes an economic loss of about $500 million per annum. Next slide, Anna. Universal access to malaria diagnostics is one of the core strategies in the World Health Organization's test, treat, and track policy for malaria control in endemic countries. Next slide, Anna. There are 2 malaria diagnostic methods currently used in Uganda. That is microscopy and rapid diagnostic tests, RDTs. Microscopy, which is the gold standard, has the advantage that it allows for parasite species identification, quantification, and determination of the life cycle stages. All these are important to guide treatment and monitoring of impact. It's also cheap and costs about $0.1. However, it is time intensive, requires special skills, and has a long turnaround time. RDTs, on the other hand, are easy to use and give almost instant negative or positive results. As such, they can be used at the lowest healthcare facility, that is the community and Tier 2 facilities. However, unlike microscopy, they do not quantify the infection, they are unable to tell us the life cycle stages, and they are unable to tell us the species. They are also expensive, costing about $1.5 per test. Because of gene mutations that have recently occurred, they are prone to negative test results, which leads to delayed treatment, progress to severe malaria, and sometimes leading to death. Next slide, please. Owing to its abilities, already mentioned above, microscopy is the recommended malaria diagnostic method at Tier 3, Tier 4 hospitals and tertiary health facilities like the regional referral hospitals. However, There are no expert microscopists at the tier 3 facilities, and these are the facilities that receive the highest volume of patients that require diagnosis within Uganda's healthcare system. So this creates a backlog at the tier 4 facilities and also the tertiary facilities to an already overwhelmed system where we only have 30 WHO certified microscopists. Next, please. To counter the challenge of RDTs and current microscopy, there is need for a low-cost automated malaria diagnostic device able to identify and quantify malaria parasite infections without the need for expert microscopists. I'll now hand over to my colleague Matt from JHU to tell you about our proposed solution.
Thank you, Jocelyn. So this is where our solution comes in, a low-cost automated microscopy device that analyzes patients' blood slides to detect malaria parasites. The device consists of a hardware and a software component that when combined can perform the automatic detection, quantification, and speciation of malaria. The team is collaborating with Prakash Lab at Stanford University, who has developed a system capable of automating the slide imaging process. This battery-powered system is modular and incorporates a high-resolution image sensor. The motorized precision stage and autofocus adjustment provides the ability to acquire high-quality images from multiple fields of view. The software component is being developed using a convolutional neural network to detect parasites in red blood cells. It does so by first isolating individual RBCs and cropping the image into single cell segments. Then the algorithm categorizes the cell as either positive or negative and determines parasite density, species, and life cycle. The science behind this solution has been de-risked by others who have developed similar CNNs for specific pathology analysis. However, most of these algorithms were created for research purposes and none have been incorporated into a complete low-cost system that automates the image acquisition and slide analysis process. We are confident that we will be able to get this device to Ugandan clinics due to our great local support. During our travel to Uganda in March, we had the opportunity to speak with and create relationships with individuals that are ready to bring this device to both public and private health facilities in Uganda. We spoke to people from the National Malaria Control Division, Central Public Health Laboratory, Ministry of Health, and many of the expert microscopists in the country. In these interviews, we were able to validate the need for an automated microscopy analysis device, and we received very positive feedback. In addition, we also received generative usability feedback that will be incorporated into a minimally viable product in the upcoming months. One of the most impactful responses came from the Director of the Ministry of Health, Dr. Jimmy Opiko, who mentioned that this will help bring the country one step closer to malaria elimination. So far in our product development timeline, the team has been able to validate the importance of the need and the specific design requirements, perform in-country customer validation, develop a proof of concept, and determine a preliminary willingness to pay for the device. It is our goal to reach each milestone with a sense of urgency and determination so that we can contribute to the national malaria elimination drive in Uganda.
So we're asking for 50K as a bridge. It's not a drop in the ocean. This project does not have significant amount of NIH and Gates funding yet. It's not a social venture yet, but it can be. This 50K will be catalytic in translating this proof of concept to a functioning MVP so that it can realize its full potential. Last slide. And with that, we'd like to thank you all. We're a team, multidisciplinary team at Center for Bioengineering Innovation Design with lots of collaborators within the Hopkins as well as international ecosystem, and with a track record of translating things like this into products, into companies that are now serving patients across the globe. So we hope that this too could go on that journey. So thank you for your support, and this 50K would be catalytic in helping this team accomplish that.
Thank you very much. Another great presentation. It's going to be very difficult for the judges, I can see. These are all great ideas. So let's turn it over to the questions. So Alain, you get the first question, and then Julie, you're following that. So please go ahead.
Thank you so much, Jeg, for that great presentation. This is a space that has been rife with innovation now for over a decade, leveraging AI and computer vision for malaria triage and diagnosis. Could you maybe highlight the key differentiator of what you're proposing from other technologies that have used sort of cell phone based malaria screening systems?
Yeah, Matt, do you want to take that? I can get started. I think you're right. There's plenty of science and preliminary work that has happened, but we do not see in country across country in Africa a product that has been developed with user-centered design principles that's rugged, robust, and is available in tier 3, tier 2 facilities. So I think there is really not a core scientific differentiator or a core algorithmic differentiator. It's just a group of designers who are doing a lot of iterative user-centric design to make this as a product that can sit at an affordable price point at tier 3 and tier 2 facilities. Matt, do you want to add anything to that?
Yeah, I can add that some of these other innovations, such as the NIH one that was focused on creating a phone app, it doesn't allow for the analysis of the different life cycles and the different species, which adds a lot of value towards the treatment pathway and management of the disease. So while this system was created more as a research device to just detect the parasites within red blood cells. So our device adds more value than that.
Great. Let's go now to Julie.
Yeah, I was wondering about the overall, when you're looking at the final implementation of this type of system, the overall cost, and if there was possibility for centralization of this sort of, if images could be sent to a central facility to reduce cost and make this more widely available than having individual systems in each place.
Yeah, either one is possible. I think we initially were positioning this for tier 3, maybe even tier 2 facilities. Tier 3 facilities, for instance, where the burden, like the large number of rural patients do come in, except there are people who can draw blood slides, according to the Ministry of Health, according to what we saw, but there aren't enough trained microscopists at all who can read them. So yes, it could be centralized. You're right. There's a huge backlog in tier 4 facilities as well, which is at the central locations, where this device would also meet a huge unmet need. But I think the true kind of potential for this will be in tier 3. So we are designing this with that in mind. And to your point, I think we do aim for this to be integrated to a centralized like DHIS2 backbone. We're also in conversations with how Uganda does implement the DHIS2 so that all of this is available to at
We're at time, thanks.
And maybe just to add to it, with malaria, we need an almost instant test results, and then treatment should be given according to the test and treat strategy. Otherwise, we risk the patient transforming to severe malaria, which can result in death. So placing it at the tier 3 and also tier 4, where we have high volumes of patients, will be good. And as Prof has mentioned,
No, thank you,
Jocelyn.
That's a great answer. I think we're out of time, and but thank you for adding that important point about the timeliness. And speaking of timeliness, we're going to please give a round of applause. Another great presentation. There are questions in the Q&A for the team to answer, and we'll move on to the next group, which involves Julie Dennison from School of Public Health and Nicholas Gillen from School of Education, and a team that includes those from Zambia. This is about a peer mentors program for adolescent and youth and young adults with living with HIV. So we'll bring it over to the team. And Nicholas, I don't know who else needs to be on the presentation, but
thank you so much. We need Alex and Rima to be pictured as well.
Great.
Dr. Sam Meady as well.
Thank you.
And our co-PI, Julie Dennison, is on the telephone, and she is also available and will help with answering questions.
Great. So please go ahead.
Hello, my name is Rima.
Hi, my name is Alex Fisher.
We are here to promote healthy equity for youth living with HIV. We are former youth peer mentors from a program called Project Yes Youth Engaging for Success. By mentoring youth living with HIV, we changed self-stigma and we supported viral suppression. In Project Yes, we use ourselves as a resource for people like us. These sound like mere stories, but ours are not mere stories. And we improved, they are not mere stories. We improved outcomes of HIV in young people had challenges like we did. One thing is for sure, we came out of what we once felt like was a hopeless situation. Now we are full of hope and we want to give hope for our fellow youths. In 2020, CDC named Project Yes was the only evidence-based intervention. Today, it is still the only CDC-based intervention that was developed and tested for youth living with HIV in sub-Saharan Africa. Sadly, in 2020, Project Yes ended and COVID also struck. There was no scale up. This in short meant that other young people who can greatly benefit from our interventions such as Project Yes have not yet been able to. However, we are here today so that you may grant us with this grant so that we'll be able to have development in our youth peer mentors that will help us also grow in the numbers of youths that will be able to mentor other young people living with HIV. So what will we do with this grant? We'll build our skills how to scale up a program. We'll learn things like how funding decisions are made in Zambia. We'll work with the JHU School of Education strategy to figure out what parts of Project Yes need for scale up. And this will help us strengthen mentor training and mentor development to have expert youth peer mentors to support youth living with HIV. We'll hold meetings with the stakeholders and create a plan for Project Yes.
Why should you invest in this project? Because we as youth take the lead and there are things you should know about us. We are game changers. Youth living with HIV often lead a life of fear and shame. We as peer mentors changed that through Project Yes, as we helped youth themselves positively and how taking their drug is important and helps them to be free. Youth need Project Yes more than ever. If we hope to make things better for youth living with HIV, we have a clean plan with youth at the center. We are ready to learn new skills, offer new insights, work with mentors from JHU and other Davidson Children's Hospital. No one is more committed than us. This grant will get us started and give us skills. Our commitment will not end with this grant. We will use it as a launching pad to grow something much bigger. There is no solution for us young people without us, the young people, at the center. Investing in this project places youth at the center to address challenges affecting young people with HIV. We know how to address inequities. To be here, giving the pitch, you need to have a computer, internet access, and cover transport costs. Many youth we work with do not have these items. We are here today to speak for these youth. Now, one of our mentors from the School of Education, Nick John, will speak.
Hello, my name is Nicholas Gillen, and I'm with the Ideals Institute at the JHU School of Education, and we are excited to work with this dynamic and powerful team of youth. Dr. Sam Meady from the Arthur Davison Children's Hospital in Zambia, and with Dr. Julie Dennison from the School of Public Health to enhance and scale up Project Yes. At the SOE Ideals Institute, we specialize in developing learning systems and scaling up training programs using a proven strategy, a competency-based workforce development model. Very briefly about our model, we begin by establishing the key competencies that individuals need in a given workforce. We build from the foundation of what individuals and teams have already learned, and we provide multiple types of learning opportunities before evaluating competency in job-embedded settings, leading to a formal credential. This model applied to Project Yes will provide a benchmark for ensuring quality and show funders and healthcare authorities the tremendous potential of Project Yes.
Thank you. So I am Sam Meady. I'm a pediatrician with the Arthur Davison Children's Hospital and have been working with Julie Dennison for more than a decade now, testing and creating successful programs for youth living with HIV. Now, it's important that we recognize that Zambia is actually struggling to reach epidemic control for HIV. And This is so in particular because young people lag behind, and Project Yes is a homegrown solution that can contribute and accelerate progress towards epidemic control for Zambia. And as an HIV clinician with more than 15 years of experience, I see more hope for our young children, young people, and youths once we get them involved. And this project and our partnership with the youth and the School of Education and the School of Public Health at Johns Hopkins is something we need so that we leave no one behind in our march towards epidemic control as a country. Thank you.
Well, thank you. That was another excellent presentation. And we've got an extra minute of questions. So that's also very good. So we're going to start the questions, this time with Tom Quinn. And then we'll go to Tony after that. So Tom, over to you.
Yeah, thank you very much. Obviously, a very important issue, and your dedication is readily recognized in good presentations. Quick questions. How does it differ from DREAMS? The number of people you'd like to try your intervention out on, and then what are your outcomes, measurable outcomes, if you can do those three?
If I may ask, just for clarity, I mean DREAMS as in the USAID or PEPFAR-funded DREAMS project in multiple countries?
Correct.
Okay, so
which
just
is
want to start
focused on young women, youth, women.
Yes. So one thing that we need to know is that 95% of children may get HIV from their parents, and therefore there isn't so much of a gender imbalance or gender inequity in that particular aspect. DREAMS focuses on girls and not so much on males or boys or male youth. So that is one of the differences. And in particular, the focus of DREAMS has also been to try and prevent HIV infection. This focus is on youth that are actually themselves already infected with HIV, regardless of how they got it, whether it's horizontal or behavioral acquired, but it focuses on youth that are already infected with HIV. So I think that's part of the fundamental difference that we may have with Project Yes, but also Project Yes recognizes the fact that this is a homegrown solution that we think has shown impact in the past in terms of reducing viral suppression for our country, for our adolescents, but can also be scaled up to other regions, but also to other youth in the country. Yeah, that's, I think, the first answer to the first question. Julie, you want to come through on the other aspects?
Sure. So ultimate reach, because it's an evidence-based intervention, we would like to reach youth throughout Zambia and the region. We think there's a lot of potential for this project. In terms of, I believe the last question was measurable outcomes. I think it's in steps and stages. First, we need to gather and develop our capacity. How do we scale this up? And what do we need to know in the Zambian context? Who are the key players? How can we advocate? So one is capacity building of our youth who will be engaged in this process, some of whom you're meeting today. The other measurable or actual concrete output would be an advocacy plan and to start implementing that, ultimately leading to an implementation science research protocol where we have the Ministry of Health engagement, the key stakeholders engagement to actually scale this up in Zambia. We don't know right now. We're going to use human-centered design. We're going to reach out to the key players. We're going to build capacity. So we don't know if that means starting in one province or 5 sites or throughout the country. So that's part of the beauty of this, is that these youth will help us figure all of that out.
Thanks.
Another key and important impact and outcome of this program is that you heard the powerful speeches of Alex and Rima, and that Project Yes helped go from shame and self-stigma into hope. By adding an intervention from the School of Education, we're going further than that to professional competency and professional respect.
Thank you. Very, very ambitious. Tony, your question.
Yes, thank you. I'm very excited about your project. Could you explain a little bit more about how you intend to reach youth and get them to buy into this project and participate in it?
I can answer that if the team wants me to, or Sam, I mean,
Yes,
with Project
I can
Yes.
pick it up.
Okay, we've got a few minutes or a few seconds.
Okay.
Rather. Please go ahead, just quickly.
Thank you. So we are actually targeting youth and that are living with HIV, and these essentially may live lonely lives, but essentially the health facility is still a facility that they visit, and it's in these facilities that we have fellow youth that live with HIV, like Alex and Rema, that actually want to provide support. So we leverage the existing health infrastructure, and it's in this context that we are working, or we want to work to continue working with the Ministry of Health to ensure that we reach out to these youths who are already living with HIV but seek services in health facilities. And that's where Project Yes has a critical, pivotal role to play.
We're at time. Thanks.
That's awesome. If we could give a round of applause for this team, and thank you for joining us. Particular shout out, thank you, Alex and Rima, for joining us and sharing with us your ambitions and your experience. So let's move over to the final presentation. We have yet another great team. This is with Nancy Glass from the School of Nursing and Gabor Aurora from the Krieger School of Arts and Sciences. Welcome. Is there anyone else who should be on the screen?
Yeah, Virginia Perez from Bolivia.
Excellent.
Hi, everyone.
Okay, so over to you then.
Great.
So shall I go? Greetings, everyone from Bolivia, from cold La Paz, in the high, very close to the sky. Bolivia is the third country with the highest rates and incidence of domestic violence, GBV, and violence against women and children. UNICEF Bolivia has been here for 50 years. And guess what? We haven't been able to reduce the incidence of violence. And the pandemic hasn't helped, of course. As you know, you may guess, the pandemic has only increased the risk of violence against women and children, and the barriers for the survivors to access services. So I guess we're doing something wrong, right? Perhaps is that we've been doing exactly the same thing for the last 10, 15, 20 years. And not probably just UNICEF. I was looking at the launch of a campaign/strategy on prevention of violence in the schools by our Ministry of Education with my colleagues and some other UN agencies. And I just thought, like, how can we still be using these handbooks that they have this kids design that remind me so much the same kids design and handbooks that I used in school many, many years ago, not to mention how many. But I thought, look, pandemic brought us some negatives, some positive things and opportunities, but has definitely threw all of us into the online world, into the technology, into the phone, into the tablets, into the apps, into the TikTok. And it has also thrown all of us into the online violence, into massive online messages on gender inequities and gender stereotypes that subtly keep promoting intimate partner violence and GBV and toxic dynamics and toxic relationships. And if we are all in there, particularly young people, and you know, let's be clear, we very often picture violence between a couple in their 30s, probably in a stable relationship, probably already married with children. But violence in a relationship and gender-based violence starts much earlier. It starts at 13, 10, when our kids, our children, are starting dating their classmates or pretending they're dating. So if they're all in there, that why aren't we, from the organizations that have to fight gender-based violence, why aren't we there? I strongly feel that we urgently need to do things differently, that we need to try and we need to test and pilot until we find a very effective solution, because we can't afford to keep our girls and our women exposed to violence for another 20 years or for another 10 or for another 5. You know, one victim of sexual violence is one too much. So we definitely need something new, and we need something that is adapted to their preferences. We need something that speaks young people language, that speaks women from certain groups language, and that it really has an impact. And for God's sake, something that is not up down, something that is not a teacher reading and telling their students, or there is an adult telling young people, this is how it is. Okay, we have access to a lot more information than we used to 20, 30 years ago when we were in school. And we are overwhelmed by information reaching us. So we probably need to get to the next step and perhaps experiencing, I don't know. I reach now out to my friends and colleagues, Gabo and Nancy, and I reach out to all of you in search of solutions, in search of help, because I feel that we all, as a society, have the moral obligation to stop what is the silent pandemic that has gone through for too long. Over to you.
Thank you. Hi, I'm Gabo. I'm a creative technologist. I'm in the Krieger School. So a lot of this is something, I'll just share my screen briefly here, is something that we're calling Paradise. And it's an app that young people can download. And it basically uses new technology and creates a kind of game between people doing it and couples. And it uses technology like binaural audio, which gives you this immersion that gives you a sense of presence and helps deal and communicate with a lot of these types of issues. And then it has AI elements using natural language processing, where as you engage with it, you're able to the app is able to customize a lot of what you're doing. So I think I have a short video that has one couple going through it. We did debut this in South by Southwest in the North American context, and we're now looking to partner with Virginia to use those findings and do something in Latin America that's more relevant to be able to be scaled. But Virginia will talk to that really quickly. So I'm just going to play, sorry, 1 second. Just play a short video, and then we'll hopefully.
Please be warned. Paradise explores themes of violence that might be upsetting. Dark field radio. Cover your ears with dark field radio. Please answer yes or no. Are you in a committed relationship? You have answered yes. You are fortunate. You have something that is increasingly rare, and we hope our program does not damage what you have. Are you a woman? Yes. Sometimes a mate, showing tremendous promise, may fail to live up to expectations. There are 259 couples online.
Pretty intense. Like you don't know exactly what to expect when you're coming into it.
Very immersive. When you're doing it, it really feels like you're in a room with people talking in your ear and things moving around you, and it really puts you in the headspace of the conversation very quickly.
Lesson 6.
We're at time.
I'm sorry. Do you consent to enter this lesson?
Okay. So that's where we are.
Thank you. It's good to hear the need and to see what you've got there as well. So this is, it's going to be very difficult, I can tell. But let's move over now to the questions. We are starting with Alain. So please go ahead, Alain.
Yeah, thanks for that very innovative approach to leveraging, addressing an important problem. Can I ask you what you feel is a major threat to the success of this project?
Great question. I think, it's an app. It requires people to download it. And I think, if it isn't properly done with the right sort of curriculum and encouragement, it's very hard for people just to download any app and just do it. So I think we need to do a lot of user testing of how we get people to commit to sit down and then actually get into the experience, because we're confident when they're in it that they're very much engaged with it and we feel like we can make a difference. But if not, I think that's where the curriculum, thinking about how we bring in partners like Virginia that can kind of implement it in existing, populations that can be encouraged that this is something new, is how it would work. But I think if that doesn't work, I think it becomes very hard, because I think we all go on mainly 3 apps in our life, a news app, Gmail, and maybe Facebook, and we're not as inclined to download other apps in of itself.
Thanks. Julie, over to you.
Sorry, there we go. I'm guessing you're probably going to get to this, but the major outcomes that you're hoping to achieve, the number of people that you're ideally going to recruit into this, and then the goals in recruitment.
Yeah, Virginia, maybe you could talk about scale and replicability.
Sorry, Julie, I couldn't understand the question.
Oh, sorry. The number of people you're trying to recruit into the study, and then the major goals of that. If is this mainly education of those people? Are you going to be helping people out of abusive relationships if they're in them? What are sort of the final aims?
Yeah, the interesting thing of that can really apply to be adapted to different audience, different age group. We're really keen in testing it and working with adolescents. Probably work, I don't know, we'll have to estimate with Gabo what is an adequate number, but I think for us it's not so much about number, but having a variety of backgrounds being tested. We're very interested in 14, 15, 16, 18 age group, middle class, tech savvy as much as any adolescent is now, and they have a cell phone, but it's not a complex cell phone. And that have been very much exposed to a lot of, I don't want to say information, but media culture on relationships. And what we really want is to identify what are the triggers, what are the cultural factors, the identity factors that are developed at that age that much later on could end in intimate partner violence. Okay, as we said before.
Great, thank you. So that was again great presentation and some tough questions. And let's give a round of applause to the team on the that's I guess working in Bolivia and Guatemala. But thank you.
All right. Thank you.
Thanks, everybody. So we're come to the end. This was really an amazing session. If you just to remind people, there's still a few chance to put in questions in the Q&A, and the teams can answer if they want. We heard some fabulous, well, actually every idea was great. I wish we could fund all of them, and I hope that they all do get funded and can implement them. All of them involve some innovation that involves both technology and social innovation, and people with really good important issues that can address health equity. So really pleased to hear all the ideas and the things that are coming through. But we have come up against time, and we do need to move on to the student poster session. So I'm going to thank everybody again, and please a big round of applause to everybody. And I will, before handing over to Megan, just to say our plan is to have the judges who are the questioners to review the proposals, and we're hoping that by Friday we will be able to. The plan is to announce on Friday. So thank you, everybody, and I will this time turn it back over to Megan, who can tell us where to go next.
Good morning, good evening, good afternoon, everyone. It is my great privilege to introduce Professor Sabina Rashid, Dean of the BRAC James P. Grant School of Public Health. a 2018 GE Heroine of Health recognized at the World Health Assembly, and a 2011 Fulbright Scholar. Dr. Rashid is also director of the Center for Excellence in Gender, Sexual, and Reproductive Health and Rights. She was trained in medical anthropology, in which she holds a PhD and master's degree from the Australian National University in Canberra, but she's also a visiting professor at the Berlin School of Public Health. She's highly cited and recognized global health scholar, anthropologist, and advisor to WHO and other international and national expert bodies, and has worked tirelessly to bring outstanding leadership and vision to the public health community in Bangladesh and around the globe. Dr. Rashid, thank you so much for joining us today to cap off the 2022 JHU Global Health Day.
Thank you so much, Alain. It's a pleasure to be here and it's an honor. That was a very generous introduction. I'm not sure where you cut and pasted some of that information, but I'm happy to say thank you. And, you know, I think I've just had the pleasure of working and living in Bangladesh since '93. I moved back in my 20s and joined BRAC, the NGO, and then joined the university and have been dean for 9 years. So today I've been asked to talk about decolonizing global health. And I think while we have challenges and failures, there's also possibilities and ways of moving forward. We are a self-financed school, self-funded. We have a research and academic institution and an international MPH program. And it's really great to see some of my alumni at Johns Hopkins today in this Global Health Day. So what does it mean, decolonizing global health? I think the process is just beginning. There's a long way to go, but I think what I really want to focus is on education and research as an academic, and talk a little bit about some of the challenges and what are the possibilities. There are now numerous conferences, websites, webinars, articles, blogs. People are writing about decolonizing global health. And increasingly in the States, you've had the Black Lives Matter movement. You've also had growing calls about, you know, more inclusion of women in leadership positions in global health. Organizations and some institutions are pledging or have pledged a strategic approach to diversity, equity, and inclusion. But, you know, let me just remind you, decolonizing global health is a very complex term, has complex meanings, and has different meanings depending on your positionality, your experiences, your background. But really, decolonizing global health is what? It's personal, it's political, it raises questions on the colonial legacy. There's a lot of those questions being asked. It talks about privilege, power, class, and politics. And privilege, power, class, and politics is not just found in high-income countries, but also very much in lower middle-income countries. So if I think about, you know, today we're here at this Global Health Day, and you're young students who are going to go off and change the world. I'm sure you will. You're in a very, very prestigious institution. And I ask you, so when we talk about education or research, what is knowledge? What is the hierarchies that exist out there on what is knowledge? What is valued? What is devalued? What is excluded? What is muted? What is invisible? And why? And what are the standards we talk about when we talk about education and research? And is there a cost if we have this approach? I would say yes. As Professor Abimbola argues, that we really need to pay attention to how global health organizations, institutions operate. Who runs them? Who controls the money? Who controls the agenda? Whose views, histories, and knowledge are taken seriously? He refers to a supremacy, a domination of knowledge, the way of doing things, the assumptions made of superiority and inferiority, and the hierarchies that are created. It is not simply what happens between high-income countries and low-income countries, or some people refer to as the global north and the global south, but also within high-income countries and within lower middle-income countries, because these class, power, and politics and privilege also operate in different spheres. But it's very important to recognize how a certain dominant form of public health knowledge, mainly led by high-income countries, persists in the ways of seeing and assumptions of how we do global health practice, be it research, service delivery, design. And we need to recognize when we continually, how we are part of perpetuating some of this, or how we can resist or fight back or do things differently. And many are. It's not that they don't. But there is this notion of this is universal for all, and it isn't. I've been working in Bangladesh, as I said, since 93. I've been as a professor, I'm a dean, and I've always observed implicitly and explicitly how there's geographies of spaces that are valued and geographies of spaces that are devalued. How certain kind of settings are seen, particularly the global South, are often seen as less than, be it education, be it training, be it always in need of capacity building. The knowledge bearers tend to be the ones with the technical know-how in high-income countries. And there's a need to recognize that knowledge is multidirectional, and it should be valued, all forms of knowledge. And this does take place in meaningful partnerships and equitable partnerships. I'm just talking about the dominant forms. Professor Madhukar Pai talks about a failure in global health, which he calls global malpractice, where when students who are not adequately trained or consultants who've never spent time in a global South setting fly in, fly out, and make recommendations and write papers on the health systems, make policy recommendations. And he said, if we think about it, what if students from the global South flew in and consultants from the global South flew in for a couple of days, never spent time in a certain context or setting in a high-income country and made policy recommendations or wrote papers making assumptions without adequate knowledge about that place? It can be detrimental in the global health space. While many have good intentions, I think it's important to recognize the colonial paradigm that exists in education. Since 2007, there have been some writings, at least in the Bangladesh context, about the mismatch of competencies when students from high-income countries, be it Bangladeshis or foreigners, who've never spent time in Bangladesh or certain countries, come back and they have a misalignment of skills because our populations are different, public health needs are different, health systems are different, governance is different. There's many, many differences, the poverty, the priorities, the marginalized groups. So the very issues and priorities are quite different. So there is a mismatch of competency. So what does that mean for global health training? I would argue that for those students, all of you who are on this courageous path and are going to make a difference, I'm convinced, you have to realize that global health training cannot happen in a classroom. You cannot learn global health sitting and reading textbooks and reading theory only. You have to spend time immersing yourself in different LMIC settings. You spend time with communities, and spend time with organizations, spend time with practitioners, really learning about the problems, really learning about some of the solutions, really learning about some of the issues. And I think that's really, really important. Otherwise, your training remains inadequate. So development tourism doesn't count as learning. Spending considerable amount of time is important. And I remember a good friend of mine, Sapna Desai, she studied at Harvard, she's at Pop Council in India. She told me that, there's a lot of theory, there's lots of good technical quality training, but I wish every institution had practical hands-on learning and training as part of global health, which is you spend time immersing yourself in communities, in settings. But that means unlearning and redoing content and curricula. That means co-designing, co-developing content and curricula. It means spending time and critically reflecting on what's missing in our content and curricula in many of these high-income institutions or institutions that have just copied and pasted curricula from the West, but there's a mismatch in other settings. So I really want to say that JPG, and it's not because I'm the dean or I work there, is really quite unique. And it was featured in WHO and in a Johns Hopkins newsletter for being very practical hands-on training and learning. We have faculty from all over the world, Harvard, Stanford, from ICDRB in Bangladesh, BRAC practitioners to Liverpool School. But many of the faculty have spent years in these country contexts, who are familiar, who are sensitive, who are culturally oriented. And many of our training involves spending time working with communities, not at communities. They're not objects of intervention. They're subjects and partners that we learn from, we listen, we show humility. And we have about 700 graduates from 35 different countries. And one way of doing this is building strategic partnerships, which high-income institutions who don't have that opportunity to build with quality institutions, PHFI in India, JPG, BRAC School of Public Health in Bangladesh, to offer the best of both to our students. And this ensures that we realize that institutions, there's no dependence. It's really mutual learning where there's capable leaders, faculty, knowledge, and practices in the global South that add value. As Abimbola and Pai state, trainees from high-income countries must spend a considerable amount of time in these different settings to directly learn from experts who are closest to the problems and closest to the solutions. And I think that's really, really important. We produce the likes of Fazli Hassan Abed, the founder of BRAC, the largest NGO, Southern-led NGO in the world, that is now BRAC International in 11 countries. Mohammed Yunus, who's really worked to develop microcredit, and many other examples. I know that my time is almost up, or have I got another 10 more minutes? Alain, you come on? Okay. I'll take another 10 more minutes. But I just want to say that if we look at education, the paradigm shift is to recognize knowledge is multidirectional, co-learning, co-designing, and community immersion. That is global health, learning from ground realities, lived experiences. We offer that, and many other institutions are trying to set up global health programs. And I think it's important for collaboration and partnership. Finally, I speak about research. Research is a thorny issue because many professors in different parts of the world have asked some very difficult questions around why is it invariably that money, resources, power, decision-making, agenda setting mainly is in high-income countries. It's controlled by board members and committees that are mainly led by experts in high-income countries, and why is the flow unidirectional? And what kinds of historical and colonial practices do we need to reflect on that keeps LMIC countries dependent on aid and technical assistance from former colonies or colonizers? Why major decisions in global health made in Geneva, New York, London, Switzerland, when all the problems or the challenges and the solutions lie somewhere completely different? And then you've got added issues of visas and travel and costs and expenses. I don't even want to get into that. But, and then there's the whole thorny issue that we keep talking about, authorships. And why is it dominated by many, many leaders in high-income countries, while there is equally capable leaders in LMIC countries? And this is a problem that goes on in high-income countries where, but also not limited to it, but also in lower middle-income countries where young or junior researchers are not given opportunities to lead or to write or to publish. And this also reproduces a certain system of who are the knowledge bearers of global health. But in reality, it's a much more messy and blurred, and there's innovations and solutions in many, many different countries and in lower middle income country contexts. If I think about BRAC and Grameen and other countries. So we have a trickle down problem of science from the north to the south. And I will end with a couple of things. One is that we have this kind of cycle approach where we keep reproducing systems and inequalities, and universities don't help, where there's structures around research grants and awards for priorities that are set in the north, by the north, for the north. But increasingly now you have some donors and development partners putting out calls and grants for leadership and research to be led by faculty and researchers in lower middle income countries. Secondly, you've got new journals coming up, like PLOS Global Health, which encourages leadership and writings and articles from faculty and researchers, mainly in the global south. You've got Sexual Reproductive Health Matters, that moves even beyond academia and privileges voices from communities and grassroots organizations, because that is also evidence. There's a hierarchy of evidence and knowledge. And finally, I think what we want to I want to end with, ways forward. If we think about COVID, I want to quote from this article that Dr. Richard Cash, who works with us at the School of Public Health, has been involved in Bangladesh since the 60s, and Dr. Vikram Patel. They wrote this very profound and very important piece during COVID in 2020. And to quote, he writes, "By early May 2020, more than 90% of all reported deaths from coronavirus disease have been in the world's richest countries. If China, Brazil, and Iran are included in this group, then the number rises to 96%. The rest of the world historically used to being depicted as, filled with pestilence and disease that wealthy countries protect themselves from, were faring better. Despite this situation, power, knowledge hierarchy, and our deeply colonized mindsets meant that without taking, that's mine, the power, knowledge hierarchy and colonial legacies, Cash and Patel say, without taking into context and realities of these different LMIC countries, the formula was, which is really fit for wealthy countries, it became a one-size message for all. Physical distancing, sophisticated tertiary hospital care, and technological solutions. They're not a good fit with countries with distinctly population structures, vastly different public health needs, much lesser healthcare resources, different governance systems, massive within in-country inequities, and fragile economies. And they argue that context matters and social justice and equity need to be paramount. So I end with if we look at education and we look at research, we have many steps to move forward. We have a lot of work to do. But there is a recognition, there's critical reflection. The fact that I've been asked to speak today, I assume Johns Hopkins is committed to more transformative change rather than just global speakers and workshops. And I know that Alain has spent a lot of his time in Bangladesh, but just to say that health is, public health, why are we here? We're here to really improve the lives of the disadvantaged, which means we have a responsibility. We have accountability, which means recognizing that we need to move beyond a Eurocentric model of public health education or a top-down research approach and really look into collaborations and partnerships. It means recognizing communities are at the center of our learning. It means working with communities, working for communities. And finally, if you look at what happened in Bangladesh and many countries, the lockdown did more harm than good. And eventually the government opened up its economies by June because people were starving. So this one size fits all really it magnifies the kind of approaches that we automatically and implicitly accept without any question. Finally, students, it's really a pleasure to talk to all of you, such bright minds, some of the brightest, I'm sure, at Johns Hopkins, forging careers ahead. I have one request as you move on with your journey, and that is something that I'm continually reminding myself, is that we need to incorporate, values of humility, respect for all, empathy, and a commitment for truly learning in different settings, because there's a rich body of knowledge, innovations, and solutions. Thank you very much.
I think we all virtually applaud that phenomenal talk and remarks. I'm asking the folks in the audience to kindly raise your virtual hand, and I will call on you, or feel free to place your question in the Q&A. But just as we wait for folks to formulate their questions, first of all, thank you so much for those really deep reflections. Émilie Besson, who's a researcher at the London School, recently wrote in The Lancet that to practice decoloniality is not merely to offer a seat at the table, and it's certainly not manipulating and appropriating the work of non-white scholars. It's really about critically questioning whether the table is yours to seat at from the beginning, and it's about structural changes and not just adjustments. There's really no quick and easy way to decolonialize. And I think you really reiterated that importance of reflective, intentional, respectful, forward movement in partnership in order for us to truly make changes.
Yeah, I also, Alain, I was just thinking, yes, we talk about the white privilege, but privilege comes in different forms. There's class privilege, there's economic privilege. I come from a privileged background sitting in Bangladesh. And I think, yes, decolonization is complicated, it's messy, it's complex. And I think we can resist and push back in different ways. In the school, we've set up a very clear authorship guideline that allows people to faculty and researchers to publish, and we don't become a site for data collection and data collectors. I think it's those different things. We are co-designing a curricula for those institutions in high-income countries that are really interested in and committed to really learning from each other. They value all forms of knowledge. And I think it's about taking those risks and sometimes walking away and saying, no, I've turned down grants that have no sort of meaningful engagement. Let's put it like that. It's more a token partnership.
Yeah. And this morning's panel actually brought up this issue, as you point out, of even the way in which these partnerships are framed. When we say things like North-South partnerships, we should be speaking about South-North partnerships, where the exchange of information is bidirectional and not unidirectional.
Yes.
Professor Bennett in our health systems program in the department is asked the question. Dr. Bennett, would you like to unmute and speak? I think we can give her the mic.
I can see her question. Is that
Yeah.
Hi,
Hi.
I'm unmuted. I can speak if that would.
Please, Dr. Bennett.
Thank you so much, Professor Rashid, for a really interesting speech. And obviously, this is a hugely important area. I guess, sort of building off the comment that you just made about the importance of us not just having people come to talk, but actually taking action around this. And so I guess my question is framed from the perspective of what can we do to be better partners, and trying to put that in a way that may be sort of more approachable for you. I was asking, when BRAC is looking to choose partners for research or for education, what do you look for in good partners? And are there any criteria that you use to assess potential partners? And I guess I'm asking that sort of lessons that we can take away for ourselves about how we partner with institutions in low and middle income countries.
That's an excellent question, Sarah. I think some of it's been learning while I've been doing. And what I found very interesting is that when you are faced, and we have some partners where we work with, where there is from the beginning a discussion on what does your School of Public Health do in terms of your Master of Public Health program? This is what we're doing. What are you interested in terms of priorities and needs? How can we kind of work together? Are they certain areas that you would need some technical know-how X? Are they spaces where you can provide us with technical know-how X in training, in research? And I think often it's respectful conversations. Equitable means what? You actually have a conversation about a curricula, about a particular approach. It might be even a co-designing a research tool. It might be even the ethical approval process where you co-develop a joint authorship memorandum of understanding, which is very transparent. It could be about co-facilitation rather than, I've been in situations where I've actually said no to partnerships where they've said, hello, we're from blah, blah, and we want to develop problem solving, community solutions. We have all these professors. And I said, but actually we have practitioners who teach in our program along with professors because they've developed programs, successful programs, but also failures. I want them to be part of the teaching. No, we don't, because we have a system where it just has to be professors. Sorry, I'm out. So, things that actually accommodate and understand real world public health context. The reality is some academics, I know people like, Richard Cash, who got the Mahidol Award for, ORS development, and many have produced lots of good evidence to make a difference in global health, but practitioners also, development practitioners, contribute to public health. And we need to acknowledge this and expand this ivory tower approach. We also need to acknowledge, and Sarah, it's very obvious after working in this field for a while, those who see you as a token inclusion, because, we all need resources, we're self-financed. So sometimes you have to cut corners, but as I get older and I've been dean longer, I just think for the long-term good of the school, we need to have some boundaries, and some of it's just equitable, meaningful discussions around what are the priorities in our education. We have now implementation training, right? Where we meet with donors and development partners. How can we work together and have a conversation rather than we have a guidebook, we've developed the tools, here it is, now you just roll it out, which still takes place. You'll be surprised. I'm sure you're not surprised, but I've seen it, I've experienced it. And then there's the other of how can we adapt this? Is this relevant? Is it necessary? What do you think? And I think it's really about those respectful conversations. It's about shifting in your head and your mindset that these are not some geographies of space that just can only do capacity. They need their capacity built. That takes a lot of unlearning. And then we have our own issues in our own countries, which I don't want to get into. Yeah, I hope that helps, Sarah. Yeah.
Yes, it does. Thank you very much indeed.
I wonder if we get into even developing a scorecard for feedback from our partners, where there's a process of providing that feedback either purposefully or anonymously.
I think we should also have allyship, where we also challenge development partners, because universities are set up to just reward competitive, really my territory kind of politics beyond public health. And I think those sorts of structures need to also be talked about. And, a collective force for good, that's what academia is. That's what practitioners are, the idealized version of global health, which should really now, given all that's going on in the world, should really be pushed.
Yeah, so we have a question. Unfortunately, there's an anonymous question, but I'll try to channel the gist of the question here. That many public health programs, and as we ourselves do, have immersion or field experiences for their students. Some of these are poorly organized or don't consider the burden of having students in these LMIC sites without considering the disruptions they cause. And so do you have some examples of how these types of immersive experience that you spoke about, right? Immersing themselves in the context being so
I think it's a very good question. In fact, when I first joined the school, the first few years, we used to have immersive learning in Savar. And after a while, because we have international students and Bangladeshi students, they came to us and said, look, we keep going to these communities. Either we ask BRAC to set up interventions here, because we're asking questions around water, hygiene, sanitation, or we're actually exploiting them for their time. I wasn't a dean then, I was a senior lecturer, and I thought that was a very valid point. So we had a community fair, we brought them in and asked them, what do you think about all these visits? It was a mixed response. Asked for some services. We went to BRAC. We have the advantage, we were set up by BRAC and NGO and said, we're working in Savar, 8 villages. This is what's missing. What do you think you could bring in that at least legitimizes or validates the time students go in? We also, so that was one. Second, we tend to pick sites where there are interventions. So then if there's a mismatch or gaps in interventions, we actually present to the practitioners or those service delivery organizations. We tell the communities, this is what you said. This is what we're sharing anonymously. So then there is some buy-in and you don't feel like exploiting poor people, which is what happens all the time, for your own kind of teaching and learning. But we have also learned some of this over time and put in places. We have BRAC, we have 36 national partnerships on the ground, because some of this we've been sensitized to, and we ourselves as teachers, when we go to the field, have been challenged. I mean, Motlab is a classic example of research nonstop, where communities just said, go away. And that applies to research as well. Like, what are you giving us? So I think it's a very good question. So we've tried to put to the best of our ability structures in place to minimize that kind of exploitation.
So I think the other important point you raised was the issue of representation, and representation on decision-making boards, representation with regards to funding decisions. How have you been able to achieve successes in advocating for representation to change this paradigm?
Well, I'm very vocal anyways, and I've also served on some boards and where there's like-minded allies. I think part of it's being strategic and finding like-minded allies. It's not a world that's black and white. They're on that side, we're on this side. There are many people who want to work together. Like I've been pushing for social science and qualitative and ethnographies in public health schools. So on various boards, I will talk to allies in Southeast Asia, in the UK, and say, how do we push this agenda? It's the same thing. Sometimes you get shut out. You get accidentally dropped from some committees. If you're too vocal, it's a fact. If you challenge authorships or you're seen as a troublemaker, and it's just not me, I think for a lot of people who may challenge the status quo, but the rewards far outweigh the some of the risks. But I think I'm also in a position, a privileged position as a dean and as a professor. If I don't speak out, then I also cannot keep going on about these things. So I also have a certain accountability and responsibility to say when I disagree, where I feel strongly about representation. This is also structural. It's who you know, the networks. And once you get into one network, you get into 20 networks. And it's a bit of a serendipity with networks and who you know and who you kind of, meet in conferences and meetings. But you still have to say your bit and you still have to be heard. I think you need to pick your battles and you need to pick wisely, but it doesn't mean you don't say anything. Yeah.
And I think that's a wonderful note to end on. It reminds me of the quote by the late John Lewis, who said, never ever be afraid to make some noise and get in trouble, good trouble and necessary trouble. So I think hopefully we can consider ourselves to be good troublemakers and allies alongside yourself.
Thank you.
We look forward to really making inroads as we continue to dismantle some of these.
I see Rosemary. Yeah. Hi, Rosemary. Yes, thank you for inviting me. I really appreciate it. It's a real privilege. And I'm sure I'll see you in Dhaka soon.
Lovely. And with that, let me invite Professor Tom Quinn to also add his vote of thanks and bring closure to this exciting Global Health Day 2022.
Thank you, Alain. I also want to express my deep gratitude to Professor Rashid for an outstanding keynote presentation that ends today's activities. You really brought everything together and provided your own insights into the theme that we've been really struggling with today. Not struggling, but really trying to rethink the global health through this synergistic, as the term goes, co-creation or decolonization. That we want to, I for one, like to move away from decolonization, although I believe in the theme of decolonization. So we use the terminology co-creation, synergistic, working together to a common goal of equity and good health for everyone. Really having those partnerships that are equal, that work together, that really address the community's needs. And it's been interesting reading all the questions throughout the day. And I hope before you all sign off, take a look at some of these questions and probing. A lot of issues coming up about how so many times we're so research focused, but we're losing sight sometimes about the practice of health within certain countries, certainly our own. And obviously, global health is local as well as global. And many of the things that have been discussed throughout the day, starting really with the panel. And the panel was just outstanding. And I really want to thank our experts for their perspectives and their insights into the whole topic of global health and how we do need to rethink it and go to global health 3.0 or whatever number you really want to pick. And then that panel was followed by these outstanding, innovative pitches of great concepts and ideas that would, if funded, would really take off to improve the daily health of many, many people. We went from ocular disease to malaria diagnostics to HIV and use, and I can go on and on. There were 6 exciting projects that were presented. One will get funded. and it's going to be tough for the judges to finalize that. And then, of course, the posters, where we really got to experience what our own students have been practicing. So there's one thing to learn in the classroom, but to then actually have that field experience is so rewarding and so educational in its own fact and transformative, leading up to what you professed in your presentation just now of all those equal partners and the excitement, enthusiasm of the students and the practitioners working together to solve the current health problems that face us all. Take a look at those Q&As, look at the chats. We've had people from all around the world participating today. It really has been a rewarding experience for me. I've learned a great deal listening to all of you. And I hope those who have tuned in also shared in that educational experience. There will be a recording available of the whole day or of each individual session. It will be posted on our website, which is hopkinsglobalhealth.org. So if you want to hear some of the exciting presentations of the day, that will be posted. Give us a little time to collect it and to get it on our website. And obviously, as we get towards the end of the day, it's my responsibility to thank the organizers and the people that made this happen. And so my deep gratitude goes out to Alain, who really helped put this on our timetables to getting this completed. Megan Harrison, who really made the format work and reached out to everyone and really made this a seamless presentation throughout the last 4.5 hours. Anna Kabarzik, who worked closely with Megan to make this help. Michelle, who's been helping us throughout the whole planning process. And really to the Department of International Health and all those who tuned in and contributed in their own ways in discussions and presentations and so forth. Many thanks to David Peters in the Alliance for a Healthier World, who really put up this award for those people who have the teams that have worked together to make their pitches to getting their projects off the ground. Again, a very rewarding day. I wanted to reach out to Megan to see if there's any way the Gather platform could stay open so that they could go and look at some more of the posters. I don't know, Megan, if you can answer that.
Absolutely. We can keep that open. It'll be open for the rest of the afternoon, actually. So I'll go ahead and just post that link here for people to go ahead and mingle and look at the posters. And yeah, we can keep the party going if we want to.
Well, I think, because the time was limited for visiting the posters. And normally we don't do that virtually. We do it in person. But because of COVID and limitations by the school and our ability to gather, we need to do this virtually. And I want to encourage everyone to go back to the Gather program platform and really experience what many of our students have done over the past year. I mentioned in my introductory remarks that this year was another record for applications of our students and faculty to be working in teams working overseas. Over 100 applications, just truly amazing. We had enough funding to do 40 to 50% of those, so I'm very pleased to say that. We have our residents and fellows who are also receiving awards to contribute their knowledge in the health practice to work overseas as well. Good news on all fronts. And the last announcement I'm going to make is we just heard, and this will be more formally announced, that in a partnership, a consortium of the University of North Carolina, Chapel Hill, Johns Hopkins University, Morehouse School of Medicine, and Tulane University have just been renewed for the coming 5 years for a Fogarty grant entitled Launching Future Leaders in Global Health, or LAUNCH, which actually involves 100, or in the past, 100 pre-doctoral students, postdoctoral fellows being trained, not just from the US, but also from low and middle income countries, to spend a year immersed in field projects, working with many of our international partners, including in Dhaka, Bangladesh. So I really want to congratulate the investigators of that program. Stay tuned. Keep a watch out for on our website regarding opportunities of that particular program. We will be heading up what's called the Research Leadership Academy. Baki Hansadi will be very instrumental in that. She's one of our associate directors of the Center for Global Health, working with Anna and Megan. So enough acknowledgements. I want to thank everyone who has tuned in and been part of today's activities. Professor Rashid, thank you so much for joining us and for giving us such an exciting, insightful keynote address. We appreciate your time.
Thank you.
With that, thank you. Alain, thank you for your moderation throughout the whole program. And everyone is welcome back to the Gather platform if you'd like to go see more of the posters. Thanks very much.
Thank you.
Megan, I'm going to let you close out the program here.
All right. Thank you so much, everybody. Again, thank you, Tom. Happy birthday. Thank you, Alain. Thank you, Professor Rashid. And yeah, thank you to all the attendees. We really are so thankful that you've chosen to spend your day with us. And we hope you have a great rest of your day. See you in the Gather. Bye.
Bye.